information. Soon, the 2022 ASEAN-ROK International Conference. 소리 안 들어와요. So the conference will start soon. Please take your seat.
네, 그럼 지금부터
Now, let us begin 2022 ASEAN-ROK International Conference on Response to Infectious Disease, hosted by the Korea Disease Control and Prevention Agency and organized by the Korean Human Resource Development Institute for Health and Welfare. Everyone, welcome to the conference, and I'd like to welcome you all. Hello everyone, I am your host for today. My name is Yeonjin Kim.
네, 오늘
Today's conference has participants not only from Korea but from 10 ASEAN countries as well. Today we're going to not just share our information unilaterally but share each nation's know-how and experience together. Today we have 3 sessions and also we have a variety of programs. So the participants watching the conference online, please stay with us until the very end of the conference. So the response to infectious disease cannot be achieved by one nation's effort. That is why we are gathered here to share our know-how and ideas. And this is a lot more meaningful as we are convening this event offline in the wake of COVID-19. And also this conference is being broadcasted live on the KDCA's YouTube channel. Please pay attention to the online program as well. And also on YouTube, you could set your preferred language between English or Korean. And this conference is being broadcasted live, so please make sure you leave your name and ID. And today, simultaneous interpretation is being provided. Please make sure you use your interpretation device located on your desk. Channel number 1 is for Korean, channel number 2 is for English. For today's conference, we have many distinguished guests. So I'd like to introduce the distinguished guest. Whenever I call a name of each participant, please welcome them with a big hand. Today we have Mr. Kim Hyun-jun, Vice Commissioner of the Korea Disease Control and Prevention Agency. Thank you for being here with us. And we have Mr. Park Kwang-taek, Acting President of Korea Human Resource Development Institute for Health and Welfare. Thank you. And we have Professor Lee Jong-gu, Professor at Seoul National University and Ambassador of Global Health Security. And today we have Ms. Ji Young-mi, CEO of Institute Pasteur Korea. Please welcome with a big hand. And we have Mr. Patrick Abuagi, Director General from Ghana. And today we have Mr. Lee Hoon-sang, the Chief Strategy Officer of Right Foundation. And also we have Mr. Fernando, the Assistant Director and Head of the Health Division of ASEAN. And we have many other distinguished guests together with us. However, in interest of time, I'm afraid we cannot introduce each one of you. But once again, I'd like to appreciate for your participation today. So the opening speech will be delivered by Mr. Kim Hyun-jun, the Vice Commissioner of the Korea Disease Control and Prevention Agency. Please welcome him with a big round of applause.
안녕하십니까.
Good afternoon. Nice to meet with you. I am Hyun-jun Kim, Vice Commissioner of Korea Disease Control and Prevention Agency.
I'd like to welcome all of you who participated in 2022 ASEAN-ROK International Conference on Response to Infectious Disease, ARICRID, the first international cooperation project of KDCA. In October, we had the first online non-contact course of this international training program. The curriculum covered various areas which KDCA oversees as a central government agency in the infectious disease field: infectious disease response policies, emergency management, and laboratory diagnostic tests. And I have been told all participants of the face-to-face training course in November, started last week, paid visits to KDCA aimed at prevention and management of notifiable diseases, local autonomous government entities, and private institutions to see what kind of activities and roles are done by various players in Korea in terms of responses to infectious diseases, including COVID-19. I believe your hands-on experiences to see actual sites where disease policies are established and implemented yourself can be good references to set forth disease response policies in ASEAN member states. This international conference is comprised of keynote speeches on response to infectious diseases and international cooperation, experts' presentations on building cooperative system between RK and ASEAN in the public health sector, and panel discussion on measures to reinforce international cooperation to respond to infectious diseases. First of all, taking this opportunity, I'd like to extend my gratitude to all the experts and ministries in charge of quarantine who are sparing no effort in the area of international cooperation. For the second session, I'm looking forward to sharing lots of ideas through presentations on the current status and suggestions regarding response to regional infectious diseases given by the ASEAN Secretariat, Thailand, and Malaysia. In the third session, infectious disease response experts in each field will discuss response strategies such as laboratory diagnostic tests, surveillance systems, and information analysis, and epidemiological investigations, resulting in an increase in the effectiveness of this key capacity-building program by deriving an implementation plan for regional cooperation. I hope that this international conference serves as a good foundation in that the K-Health International Cooperation Project for ensuring sustainable, universal health and resilient public health system can achieve more results through cooperation with the relevant organizations gathered here. KDCA is open to all ASEAN countries' voices and promises you that it will do its utmost for reaping the best results from ASEAN-RK International Training Course for Capacity Building to Infectious Disease, which will last until 2026. Lastly, I would like to appreciate all public officials of health ministries who came a long way to Korea despite the cold weather, guests and participants of these conferences, as well as all the staff who prepared and organized the 8-day program. In addition, on behalf of Koreans, I express my sincere condolences to the victims and of Vietnamese and Thai nationals who lost precious lives in the Itaewon disaster on October 29th and their bereaved families. Thank you for listening.
네, 고맙습니다.
Thank you. It was Mr. Kim Hyun-jun, the Vice Commissioner from KDCA. Despite this cold winter, I'd like to once again, he mentioned how he is appreciating your participation, and also he mentioned the importance of our cooperation for the response toward the pandemic. And also through this this conference, I also hope we will make many fruitful results. Now, welcoming speech will be delivered by Mr. Park Kwang-taek, the acting president of Korea Human Resource Development Institute for Health and Welfare. Please welcome him with a big hand. Good afternoon, everyone. I am Park Kwang-taek, the acting president of Korea Human Resource Development Institute for Health and Welfare. I'd like to welcome all of you participating in 2022 ASEAN-ROK International Conference on Response to Infectious Disease. And also, I'd like to thank all the participants who participated in Korea ASEAN International Training Course on Response to Infectious Disease, which is a part of our ODA project. And also, I'd like to thank ASEAN Secretariat, K-Health International Project participating institutions, as well as ODA and other related professionals. And also, I'd like to thank the KDCA and ASEAN Secretariat staff members for organizing this successful event and providing your continued support. In the wake of COVID-19, we were only able to have online training and webinar. Now we are finally able to organize offline international conference, which is all the more meaningful. Korea Human Resource Development Institute for Health and Welfare is a training institution which aims to achieve universal health coverage and also providing many international cooperation-related training services. This conference today is a part of K-Health project, which is a collaborative project between Korea and ASEAN. And through this conference, I hope we will be able to share our achievement and ideas about this response to infectious disease. And today, we have many professionals in the fields of infectious disease response and international public health. By discussing your ideas and also sharing your experience, hopefully we will be able to come up with countermeasures to make our co-response toward infectious disease going forward. This conference is not only just to transfer knowledge unilaterally, but we are going to share our know-how and experience with each other. I hope this conference will be an opportunity where everyone and every nation in ASEAN and Korea could strengthen our cooperation architecture in the public health system. And also, I hope we could upgrade our expertise and strengthen our network. Once again, I'd like to welcome you all to this international conference. Thank you. Thank you, Mr. Park Kwang-taek. It was a warm welcoming speech. So today we are not just going to transfer information unilaterally, but share our know-how and experience. I look forward to your active participation and discussion. Thank you once again. And now I'd like to invite
So since Dr. Lim Jok-hoi, Secretary General of ASEAN Secretariat, is not here with us, so he sent a video message.
Excellencies, distinguished representative, ladies and gentlemen, good afternoon. I'm pleased to join you at the ASEAN-ROK International Conference on Capacity Building to Infectious Disease. I congratulate the Republic of Korea through its Ministry of Health and Welfare and related agency for convening this timely event. Indeed, today's conference is further demonstration of how the ROK has been a steadfast partners of ASEAN, which is characterized by our multifaceted and expanding cooperation. As a valued dialogue partners over 3 decades, ROK has made solid contribution to the ASEAN's community building efforts on the political, economic and social cultural funds. As part of efforts to advance ROK, ASEAN-ROK Health Cooperation, this conference is an important platform for stakeholders from various sectors in the region to engage with one another, as well as contribute to the strengthening of resilience of national and regional health systems to respond to current and future health threats. Furthermore, recent public health emergency, particularly the global outbreak of COVID-19 and monkeypox, have increased the demand for more feasible and actionable joint collaborations that are aimed to increasing capacity as well as mobilizing resources in infectious diseases preparedness, prevention, detection, and response. ASEAN is very much appreciate the support of the ROK for the initiative in enhancing the detection capacity for COVID-19 in ASEAN member states and for the contribution of $6 million to the COVID-19 Response Fund. Excellencies, ladies and gentlemen, ASEAN strongly believes that the public health challenges transcend sectoral and geographical borders. The COVID-19 pandemic has demonstrated the interlinkages between global public health crisis and its adverse impact on economic growth, highlighting the importance of collective action to address shared challenges. In this regard, allow me to elaborate on ASEAN efforts on this matter. Currently, ASEAN is enhancing the region's public health emergency coordination mechanism, including through the development of ASEAN Public Health Emergency Coordination System and the setting up of ASEAN Center Public Health Emergency and Emerging Diseases. The regional initiative will facilitate cooperation through the One Health approach with relevant partners such as ROK and the World Health Organization. The new Southern Policy Plus of ROK has deepened ROK's strategic partnership with ASEAN, particularly amidst this ongoing pandemic. The strategic partnership has jointly addressed common challenges aligned with the policy and with ASEAN initiative on post-COVID-19 recovery through ASEAN Comprehensive Recovery Framework. This framework in detail 5 broad strategy corresponding plans to overcome the pandemic and move towards recovery. This includes enhancing health system as well as advancing towards sustainable and resilient health future. In particular, the initiative focus on utilizing successful regional coordination mechanism, mobilizing resources through multi-stakeholders, partnerships, institutionalizing regional efforts towards resiliency with external partners, especially on human resources, as well as increasing intra-ASEAN trade and investment in strengthening supply chain resilience. The whole of the ASEAN response has also been realized through the ASEAN Coordinating Council Working Group for Public Health Emergencies that facilitate multi-pillar community engagements. The gradual opening of the economies has also been supported by the digitalization of and harmonization of the ASEAN Health Protocol that complement travel corridor arrangement, as well as a regional comprehensive economic partnership that provides strong anchor for greater ASEAN engagement in the global markets. I'm also pleased to note the establishment of the Care Health Project, which include multiple ASEAN-ROK cooperation projects that seeks to achieve a sustainable and resilient public health system, among others. Excellencies, ladies and gentlemen, I sincerely hope that through this conference, ASEAN and the ROK will be able to maximize the opportunities to deepen friendships and cooperation, particularly in enhancing capacity in infectious diseases preparedness and response. With that, I wish you all a successful conference with fruitful deliberation. Thank you.
네, 고맙습니다. 이렇게
Thank you, Mr. Lim Jo-khoi, for your meaningful congratulatory speech. Through this conference, we will have multiple opportunities for further cooperation. Now we have another person for congratulatory speech. We have Ms. Jung Chun-suk, the Congresswoman from the National Assembly. Please take a look. Let us take a look at the video. Hello, I am Jung Chun-suk of the Democratic Party and chairperson of the Health and Welfare Committee of the National Assembly. My sincere congratulations go to the opening of 2022 ASEAN-ROK International Conference on Response to Infectious Disease. And I would like to express my gratitude to all the officials and organizers of the Korea Disease Control and Prevention Agency, Ministry of Health and Welfare, and Korea Human Resource Development Institute for Health and Welfare for their hard work for today's event. And I also would like to welcome all ASEAN officials and ASEAN Secretariat officials. There is a saying, until everyone is safe, no one is safe. In a situation where pandemics of infectious diseases such as SARS, swine flu, MERS, and COVID-19 occur periodically, this occasion to promote cooperation to respond to infectious disease feels more meaningful. Since the initiation of ODA program, Korea has pursued a strategy to strengthen the capabilities of recipient countries rather than mere grants. As part of an ODA project, today, this event is held to share achievements and application cases of infectious disease response and to discuss development directions and cooperation plans. I believe this venue will be a place to come up with measures to strengthen our capabilities to respond to infectious disease. And as a congresswoman, I will not spare my effort to support you. Please give her a big round of applause. It was a very meaningful speech. Until everyone is safe, no one is safe. That was very meaningful. And I think that makes today's conference all the more meaningful. Today, we have professionals and experts from Korea and 10 ASEAN member countries. And together with these experts, we are going to work hard to come up with measures to respond against infectious diseases. Based on meaningful discussion and your participation, I hope we are going to have better ways to collaborate and also design better policy. Once again, I'd like to thank for your warm welcome.
Thank you very much. And we have our special guests all here. So it's time for us to take a group photo to celebrate this meaningful event today. So I'd like to invite all the guests to come forward to take a group photo.
네, 안내에 따라서 이동을 해주시기를.
Please come forward to take a group photo all together.
네, Please squeeze in. 네, 모두 중앙으로 자리해 주셨고요. 네, 정면 카메라.
Please pay attention to the camera in the middle.
네, 이번에는 자세를 좀 포즈 한번 취해 볼까요?
Now we'd like to change your pose.
을 주시고 서 주시면
Will you leave some distance between
네, 조금 자리를 지금 정렬을 했습니다. 자, 이제 기념 촬영을 여러 번 더 찍을 예정.
we're going to take a couple of commemorative pictures.
Small heart? 네, 그럼 작은 하트 한번 보여주실까요?
Please make a small heart with your fingers.
네, 고맙습니다. Thank you very much for your cooperation. You may return to your seat. 네, 고맙습니다. 이렇게 해서 저희 기념 촬영.
So we wanted to take commemorative picture with all of you. However, due to this space constraint, we were not able to take larger group picture. Please bear with us. Now we are going to officially start today's sessions. Today we have 3 sessions. In the first session, we're going to talk about response to infectious diseases and international cooperation. And in the second session, we're going to touch on building cooperative system between ROK and ASEAN in the public health sector. And in the last session, we're going to talk about measures to reinforce international cooperation to respond to infectious disease. For the last 3 years, the global society has struggled to fight against COVID-19. But still, we are faced with the COVID-19 as well as other upcoming pandemic issues. That is why we need to join our hands to fight against future potential infectious diseases based on our stronger cooperation between Korea and ASEAN member countries. So through today's discussion, we're going to come up with measures for future pandemic. So I look forward to your continued attention toward the discussions today. In order to make sure that we prevent further spread of the COVID-19, please make sure keep your masks on. And also, we are going to replace our microphone cover, and also we are going to provide bottled water in order to make sure that we prevent the further spread of COVID-19. And also today we are going to have panel discussion in the last session. So if you take a look at your brochure or program book, then you could find the QR code. Please scan the QR code and leave your comments or questions. And also the YouTube viewers, you could also leave your questions on YouTube channel. And after the conference, we are going to do some lucky draw, and the lucky winners will get some prize. So for the first session, we have many keynote speakers who will talk about our response to infectious diseases and international cooperation. Let us invite the first presenter, Mr. Babakunde Olowork from WHO. He was not able to be here with us offline, so he sent this video. Let's take a look at the video together. 네, 여러분.
The organizers for giving me the opportunity to provide a keynote speech to participants at this international conference on capacity building for infectious disease preparedness and response. Health security has been a long-standing priority for WHO and member states in the WHO Western Pacific region. And the region is continually at risk from disease outbreaks, food safety events, and other public health emergencies, including the threat posed by antimicrobial resistance. Such threats are inevitable, and their nature and management is becoming more complex. When faced with a public health emergency such as COVID-19, even the most economically developed countries have been shown to have gaps in their health system's ability to respond. In order to minimize health, economic, and social disruptions, we need to work together. Until all countries are safe, no country is safe. Preparedness together with effective international cooperation is therefore key to enhancing health security and improving the health of our populations, including the most vulnerable. Today, I will focus my speech on the work of WHO in the Western Pacific region, a recognized hotspot for emerging infectious diseases. I will discuss how we have supported countries in the region to prepare and respond to emerging infectious diseases and the role of international cooperation. I'll be using the greatest challenge that we have experienced to date for public health, the COVID-19 pandemic, to illustrate my speech using just a few of the many examples of international cooperation available. The COVID-19 pandemic has had an impact beyond health, leading to unprecedented effects on economic and social life. According to the Global Preparedness Monitoring Board, the global cost of COVID-19 to date has been an estimated $11 trillion. Between December 2019 and November 2022, in the WHO Western Pacific region, there have been approximately 96 million cases of COVID-19 reported and 279,000 deaths. This represents approximately 15% of estimated global cases and 4% of estimated global deaths. As noted by the recently published Lancet Commission report, the Western Pacific region reacted immediately and with urgency, and generally pursued a suppression strategy that resulted in relatively low morbidity and mortality from COVID-19 compared to other WHO regions. The region's early success prior to the arrival of the Delta variant may be attributed to a number of factors. These include our previous experience in the region with SARS, avian influenza and other respiratory viruses, regional solidarity, coordination and cooperation, and early implementation of public health and social measures such as the wearing of face masks. Guided by the Asia-Pacific Strategy for Emerging Diseases and Public Health Emergencies, otherwise known as APSED, and recommendations from the Technical Advisory Group for APSED, countries in the region in collaboration with WHO and partners have continued to strengthen health security systems in the region while responding to the COVID-19 pandemic. In undertaking preparedness and response activities and guided by APSED over the past 16 years, member states have drawn upon the experience and knowledge gained from past epidemics, pandemics, and other public health emergencies. This includes responding to diseases such as SARS, MERS, human avian influenza, pandemic H1N1, and other public health emergencies related to food safety and antimicrobial resistance. The Western Pacific region adopts the approach of continuous learning for improvement. This means that the response to a current event, such as COVID-19, is used to support and prepare system readiness for the next event, such as the next pandemic. This approach has enabled member states to develop strong, updated national action plans for COVID-19 pandemic response and prepare systems for future health emergencies in line with APSED. In response to COVID-19 and as an example of international collaboration, WHO collaborating centers have provided critical support, working closely with WHO to establish and strengthen laboratory capacities, especially in Pacific Island countries and areas. Next week, we are strengthening our partnerships with WHO collaborating centers. We are meeting with them at the 4th WIPRO WHO CC Forum. One of the key topics to be discussed will be health security and how WHO and collaborating centers can work more closely together to support regional capacities. Colleagues, the SARS-CoV-2 virus continues to evolve and mutate and will remain with us in different forms for years. As such, continued vigilance is required. As part of the regional effort to strengthen national and international laboratory networks for the detection of SARS-CoV-2 variants, WHO is leveraging the capacity of regional referral laboratories in Australia, Japan, the Republic of Korea, and Singapore to provide genome sequencing support to other countries in the region and to establish a regional genome sequencing surveillance network. This will support not only COVID-19 response and preparedness, but will also be applicable for future pandemic preparedness, as well as being beneficial for the identification and response to other organisms with epidemic and pandemic potential. Effective international partnerships have also been key to the rapid progress made in acquiring and rolling out COVID-19 vaccines across the region. While they are a key part of the response, it is important that they be combined with public health and social measures that are flexible and scalable to protect public health while keeping economies open. Another example of international cooperation is provided by two networks: the Global Outbreak Alert and Response Network, or GOAN, and International Emergency Medical Teams, or EMTs. WHO continues to build EMT capacity in the region, working with countries to train and develop more national teams having the capacity to deploy in response to hazards and disease outbreaks. GOAN and EMT partners have been deployed to support member states' response to COVID-19 and other disease outbreaks across the region. In this region, we have expanded membership of both networks since the beginning of the pandemic. By definition, a pandemic is not confined by national boundaries, and COVID-19 has tested cooperation amongst the international community. Our globalized, interconnected world, with its integrated supply chains, constant flow of goods, services, people, and money between nations, places us all at greater danger from this and future pandemics. The COVID-19 pandemic not only exposed fragilities of the international system, it has also highlighted the essential importance of greater cooperation. Indeed, pandemic preparedness is a global public good, and providing it requires increased global coordination and solidarity. A trend emerging since the onset of the current pandemic has been a demand for greater global collaboration in health security. Following the many recommendations made by independent review committees, expert bodies, and country consultations, the world's global health actors joined efforts to improve the global health security architecture together with WHO. To strengthen the global health security architecture, WHO is working with its member states on a number of processes at the global and regional levels. These include the Working Group on Strengthening WHO Preparedness and Response to Health Emergencies, the Intergovernmental Negotiating Body, which is discussing the development of a new instrument on pandemic preparedness and response, the Working Group on IHR amendments that is considering proposed targeted amendments to the international health regulations, the Financial Intermediary Fund for Pandemic Prevention, Preparedness and Response, and a new global architecture to strengthen health emergency preparedness, response, and resilience. WHO member states in the Western Pacific region have been involved in all the above-mentioned processes and other ongoing processes. Health security threats are inevitable, and the nature and management of these threats is becoming more complex. Economic development is no guarantee for preparedness or readiness to respond to an acute infectious disease threat, and no single country can succeed on its own. When faced with a public health emergency as a result of an emerging infectious disease such as COVID-19, even the most economically developed countries are shown to have gaps in their health systems. We therefore need to demonstrate increased international solidarity and cooperation by tackling the vulnerabilities exposed by the COVID-19 pandemic as an urgent priority. For example, strengthening health systems, investing in preparedness and preparedness plans, and addressing inequities will be especially vital, including improving access to basic services for the most vulnerable populations. In order to safeguard the health of the region, we are developing a new health security action framework based on the APSED approach that will take into account many of these challenges. The framework will also factor in the COVID-19 lessons and experiences of countries in our region identified through the Regional Learn and Improve mechanism. The new framework will focus on long-term system development to ensure countries and areas are more resilient against future health threats, including antimicrobial resistance. We have a long road ahead of us in our mission, and we will need to work together to achieve our goal of making this the healthiest and safest region. With support from WHO and key partners, as well as the commitments of member states and others to build back better, the response to the COVID-19 pandemic can be used to support building resilient health security systems towards the region's vision. In closing, I would like to express my sincere thanks to ASEAN and the Republic of Korea, Ministry of Health and Welfare, and the Korea Disease Control Agency for their leadership in organizing this event. I would also like to thank all of you for your commitment to this journey and look forward to hearing the results of your discussions. Thank you.
네,
Thank you very
보건기구 지역
Thank you very much, Dr. Babatunde, for your keynote speech. Well, with regard to infectious disease, the international cooperation's importance and all those experiences done by WHO were shared with us. And based on this experience, we can go forward reflecting all those lessons, and we will develop all these further. So the importance of international cooperation has been further strengthened than ever, and I hope this lecture gave some lessons to all of you. So we could see some of the messages supporting this event, and some were sending their appreciations to this conference. Now let us invite the keynote speaker, the Ji Young-mi, the president of the Institute of Pastoral Korea, will give the second keynote speech on global collaboration for infectious disease preparedness and response.
네, 안녕하십니까.
Hello.
It gives me great pleasure to join this ASEAN-Korea cooperation project on capacity building to infectious diseases today to share with you the global collaboration for infectious disease preparedness and response. So 100 years ago, a Spanish flu that transformed the 20th century has many similarities with the COVID-19 situation now. So as you can see from this slide, the many activities, social activities has been canceled. And you can see the picture, photos of hospital wards, and also all the children wearing the mask. And for the even outdoor activities, people are wearing facial masks and also mask fashion. And the one paper published last year compared the COVID-19 with the Spanish flu. And if you see the mortality rate, it was around the same at that time, but it was decreased to around 1%. And of course, Korea has much lower than 1%, 0.11%. And then the number of death cases also increased quite a lot, 6.6 million. And if you see the highest risk group, it was with COVID-19. We have a highest mortality rate among over 65 years old. But for Spanish flu, it was rather young, 25 to 40 years old. So after 100 years, what do we have now? So we do have global governance to deal with emerging diseases as international health regulation operated by WHO. And we do have power of science, such as testing, vaccines, and treatment. And we do have more advanced public health measures using AI and ICT. And earlier, during earlier pandemic, Bill Gates predicted the 7 dramatic ways to change the world. And much of this prediction is actually correct. The remote meeting has been quite normalized, and software has been dramatically improved. And companies can share the office on rotations. Many people are working from home. So global governance to respond to emerging infectious diseases is defined at the International Health Regulation of WHO. So this is an international legal instrument that can bind all 194 member states of WHO. It was originated from cholera epidemic during mid-19th century. So the international sanitary regulations were adopted in Paris at that time. And then later, it was revised as International Health Regulation in 1969. For that, the target disease was cholera, plague, and yellow fever. And much later, in 2003, after experiencing SARS, it was revised again in 2005. It was effective from 2007. So IHR, International Health Regulation, is intended to help prevent the spread of diseases across borders and also support countries to quickly detect and respond to disease outbreaks in their communities. So what is the public health emergency of international concern? So this is actually clearly defined in International Health Regulation. There is no clear definition of pandemic in IHR. So PHEIC is an extraordinary event that constitutes public health crisis to other member states through international spread of diseases and potentially requires the coordinated international response. And all those possible PHEIC should be reported to WHO within 24 hours through the IHR channel. And currently there are 4 diseases, even one case should always report to WHO. So those are SARS, smallpox, a new type of human influenza virus, and wild polio. So WHO IHR COVID-19 Emergency Committee has been formed and operated from January 2020 based on IHR, and I'm also participating in this committee as a member. So we had 13 meetings so far. Last meeting was October 2022. It meets every 3 months. And the emergency committee evaluate the PHEIC should be continued and also provide the temporary recommendations to WHO and member states. And recently, during 2 last meetings, we discussed the termination criteria of this emergency state and how we can also exit this pandemic. So exit strategies were discussed during this meeting. And one important thing to know is based on the declaration of public health emergency, the WHO can authorize emergency use listing of the product. So far, there were 6 occasions of PHEIC declared by WHO. The first one was swine flu in 2009 and polio in 2014, and this still continues, and Ebola in 2014 in West Africa, and Zika in 2016, and another Ebola in 2019 in DR Congo, and COVID-19 in 2020. So out of those 6, 2, polio and COVID-19 still continued. And as you also heard from Babatunde, the WHO also cooperates GON, Global Outbreak Alert and Response Network. So if you see the the COVID-19 cases and death cases globally, there are more than 657 million cases so far, and around 1% of death cases, and about vaccination, 12.9 million doses has been administered globally. And WHO said more than 20 million deaths has been averted in 2020 because of the vaccination. And then there are a framework for the monitoring and evaluation of IHR implementation proposed by WHO. There are 4 components. That there are state party annual reporting, which is mandatory, and then after action review within 3 months of the event, and the simulation exercise and voluntary external evaluation. So those 3 are not mandatory, those are voluntary, but I think this should be really mandatory to really improve, strengthen national and regional capacity to respond to public health emergencies. So I had an opportunity to participate in external evaluation of WHO in Laos in February 2017. And this was actually very beneficial for Korea, because Korea also had external evaluation in 2017 later. So the opportunity to participate in other evaluation was very beneficial for Korea. So many countries in Asia Pacific region, including South Asian countries and also Western Pacific countries, participated in JEE. And I think it is very important to really monitor the recommendations from those evaluation and revise the national action plan. So as you also heard from Babatunde, from previous speaker, we do have bi-regional Asia-Pacific strategy for emerging diseases, so-called APSET, to address national capacities in three in one framework. So now we have 3rd version in 2017. So this strategy is to strengthen national capacities required to manage emerging diseases, and it's aimed to develop AHR core capacity and strengthen the capacities required to pandemic preparedness and response. And this 3rd version of strategy has become more relevant to both developing and developed countries, because it can provide the linkage to other sectors of health security initiatives, such as bioterrorism or vaccine preventable diseases, and chemical and radiation and water food safety. And it's positioning in the broader context of health initiatives such as UHC, One Health, and climate change. So you can see the vision and goal and the objectives, as well as focus areas. There are 8 focus areas we should all focus on. And National Action Plan has been revised or being revised by different countries, as you can see from this list. And this has been guided by APSET 3. So it will be important to link with this National Action Plan with APSET 3 and also the some recommendations from joint external evaluation. So WHO leads and coordinates the strong multidisciplinary mechanism of external experts for evidence-based decision-making. So it operates a technical advisory group for virus evolution, as well as the vaccine composition, and also SAGE. SAGE is actually highest level of the expert group to guide policies for immunization and vaccines. And those technical advisory group works very closely also with the laboratory network. So in terms of R&D, we do have WHO R&D Blueprint Initiative, and this initiative was established after MERS, after Ebola, And during Ebola, WHO was criticized for late response. And the aim of this R&D blueprint is to initiate R&D even before epidemic and during epidemic, so that the public health tools developed can be used before pandemic ends. So the first, they developed the priority list for the R&D. The current list include those pathogens listed here, including COVID-19 and disease X. And first test case for R&D blueprint was actually COVID-19, because Zika in 2016 ended quite quickly. So although WHO is criticized somehow for late response, I think in terms of R&D, WHO did quite a good job. So after declaration of emergency state on 30th of January 2020, just after 10 days, they coordinated, organized the R&D blueprint the forum to establish the roadmap for COVID-19 research. So in that roadmap, which was finalized in March 2020, there are 9 areas, and WHO did a quite good job in coordinating all those researches for 9 areas during the course of pandemic. So R&D blueprint team also works very closely with the GLOPID-R. GLOPID-R is international network of major research funders in the field of infectious disease research. And it's aiming at systemic preparedness. So most important area is connecting clinical trial network. And also national regulatory function is an important part of this coordination. And building a framework for data and sample sharing, and improving the rapid delivery of research funding. So there are working groups like One Health and also LMIC working group, and there are regional hubs such as Africa and also Asia Pacific. So the Asia Pacific regional hub, in fact, Korea is leading, and definitely this regional hub initiative should work very closely with ASEAN countries. So I'm sure you all heard a lot about ACT Accelerator. So even though we developed these public health tools, that those tools should also reach not only high-income countries, but also low, middle-income countries. So for that purpose, WHO has been working closely with different global health partners, such as CEPI and Gavi for vaccines, and for Wellcome Trust, for therapeutics, and FIND for the diagnostics. So you all know COVAX is the vaccine pillar of the ACT Accelerator, and CEPI has been working very hard to reach their goal of the vaccine coverage even for the low and middle income countries. But as you can see from this map, it was not that successful, because still there are regions with very low coverage, such as African region. So if you see the major milestone of achieving 10% coverage among different income levels, so there are big gap in achieving 10% coverage for high-income countries and low middle-income countries, and low-income countries. So for low-income countries, it only reached in March 2022. So even though 12.8 billion doses of COVID-19 vaccines have been administered globally, yet the coverage of high priority groups in low-income countries are still low. As you can see from this slide, not only for the whole population, but also high-risk groups such as over 60 years old or healthcare workers, the coverage of those high-risk group is still quite low in low-income countries. And we also have developing country vaccine manufacturers network in 14 countries. Unfortunately, in Asia-Pacific region, we have more manufacturers located. But if you see this map, actually in African region, there are only very few. And this actually explains quite low coverage of African region for the vaccination. And that's why WHO and other global health partners are working closely to really improve the local production capacity for vaccines and biologicals in African region. And Korea is also working closely with WHO to, as a biomanufacturing workforce training hub, to establish global vaccine hub in Korea. So government is trying to improve the infrastructure for vaccine manufacturing. So we have been using the COVID-19 vaccine for less than 2 years now. So there are many unknowns, but we do know hybrid immunity of the combination of infection and vaccines are much higher than just either itself. And also the boosters are important. And the current vaccine can perform quite well against Omicron to prevent severe disease, although it does not really prevent infection itself. And also at least 2 doses of vaccine can lower the risk for long COVID. And, but still we do have many unknowns such as how many doses will be required to maintain immunity and what's the optimal interval between doses. So we still have a lot of things we still need to figure out, and we need more further study on those issues. And there has been some discussion to end the pandemic during last emergency committee, but of course it's not yet, it's not ready yet. So that there was a consensus to achieve the control stages for to enter into the control stages. We do have to work a lot more, because we do have quite different epidemiology of the COVID-19 in different countries. And the vaccination rate is very different. And all those surveillance and lab preparedness is also quite different. And also some countries have some concurrent health crises, such as Uganda. They also have Ebola outbreak currently. So these countries face very different situation and challenges. So we do have to consider all those different situations. So to enter into the COVID-19 control status, we have to do a lot of homework. But we do agree that the future pandemic will be probably another respiratory pathogen. So we do need to prepare for the respiratory pathogen epidemic and pandemics, as well as future SARS-CoV-2 variant. The WHO operate actually from the beginning. They established strategic preparation, readiness, and response plan for respiratory pathogen. And during COVID-19 emergency committee, we also discussed a lot about the respiratory pathogen planning and preparedness. And then a lot of policy papers has been issued by WHO, and one of those policy brief describes the planning and preparedness for respiratory pathogens. And pandemic influenza preparedness plan can be also integrated with COVID-19, and that is actually being proceeded now. So I'm sure all of you know pandemic influenza preparedness framework. So this has been discussed since 2004, but came into effect from 2011. So in that framework, so a lot of the influenza network laboratories contribute the influenza virus, and that can be shared with the industry partners free. And then 10% of global production from those companies will be shared with the WHO to support low and middle income countries. So once we decide the similar system for COVID-19, I think it can be also, this kind of framework can be also prepared for COVID-19. But we still have not decided whether we need to do the same process for COVID-19. So also last year in June, G7 countries talked about 100 days mission to prepare to develop vaccines and therapeutics and diagnostics within 100 days of pandemic. And they published the first implementation report end of last year. And they emphasized the importance of a clinical trial network and regulatory authorities function and data and sample sharing, as well as the financing for pandemics and global governance. And CEPI is one of those leading global health partners to push this agenda in the area of vaccines. So we have invested and discussed a lot about the vaccine. The vaccine area is one of the most invested area among three, vaccine, therapeutics, and diagnostics. For therapeutics, there was much less investment. But fortunately, there are some initiatives such as CTA, COVID-19 Therapeutics Accelerator, or pandemic antiviral discovery, and more recently, the Peter Doherty Institute in Australia is establishing the Global Center for Drug Discovery. So those initiatives are focusing, developing therapeutics for pandemics. I just want to show one slide for the Right Foundation. So this is a joint venture of Korean government and the Korean industry partners as well as Gates Foundation. And it has the portfolio in the area of vaccines and therapeutics and diagnostics and digital health. And do hope this initiative can also support the research and development for the low middle income countries. And lastly, I just want to share with you what Pasteur Institute is doing. Pasteur Network is a unique network of the various platforms and hubs. It has capacity for the clinical trial and drug discovery, as well as vector research. And some institute has capacity to produce vaccines and biologics. So it do have a very solid foundation in the field, and it has very close collaboration with the national health authorities. So it has capacity to respond to global infectious disease threats such as MERS, chikungunya, dengue, SARS, and so many emerging diseases. And Pasteur Institute has strength in drug discovery. So we have been working for COVID-19 drug discovery during COVID-19, and we have discovered some drug candidates for COVID-19, and those drug candidates were further proceeded to global clinical trials in different countries, like Senegal, Russia, Mexico, and Australia, and New Zealand, Nepal, and as well as in Korea. So this year is 200 years of anniversary of Louis Pasteur's birth in 1822. And to commemorate this, the Korea Post especially designed the stamp for Louis Pasteur. So I just want to finish my talk by stating the Louis Pasteur, what Louis Pasteur said. So he mentioned our goal is to turn our knowledge into practical applications to benefit people. So I do hope all of us can work together to really achieve this goal. Thank you very much.
네, 고맙습니다. 이렇게 해서
Thank you, Ms. Ji from Pasteur Institute. So she highlighted the importance of our cooperation in response to a global pandemic. We need to make sure the general public understand our knowledge. Thank you again for your meaningful presentation. Now I'd like to invite the last presenter for the first session, Professor Lee Jong-gu from Seoul National University and also Ambassador for Global Health Security. He is talk about Korea's COVID-19 pandemic response and also its limitations. Please welcome him with a big hand.
Great honor and privilege to the present, not only on the perspectives in COVID-19 outbreak of Republic of Korea, but also the perspective to global solidarity and alliance for measure of the COVID-19. My presentation will be covered from the meaning of the pandemic to the challenging issues, 5 issues. First one, my question is, this pandemic, the worst or not worst in a century? We suffered during the 100 years. So we got a lot of the pandemic disease, game changers such as the Spain influenza, Hong Kong and the Russian influenza, and the avian influenza, and recently the Ebola and the monkeypox as well. We developed responses against those challenges by microorganisms. However, human beings observed and adopted these threats, and we survived. As this figure from the WHO said, total 628 million of people affected and 6.5 million of people's loss of lives. That is 1 point mortalities. In spite of the unknown, the transmission mechanism from animal to human and its origin, the disease swept to China and spill over to spread to all countries. As you know, even though WHO World has emergency program do its best to contain the disease, at the March 11th, 2020, WHO declared a public health emergency international concern, and now Tedros head of the WHO said the pandemic is not over, but the end is in sight, September 5th, 2020. In early stage of the outbreak from the January to April 2020, China and the Republic of Korea, among 6 WHO regions, the Korea and China were high incidence countries, but now our region is lost. What Do you think about the difference in the instance in each regions before recent outbreak of the fall? What makes these difference among world? However, last 7 days, Western Pacific region reported over 1.1 million new cases, 18 increase as compared to the previous week. It is half of total all new cases in the world. Highest number of new cases were reported from Japan, Korea, and China. Even though SARS-CoV-2 has some limitation for the permanent immunization, however, it prevents severe and acute respiratory syndrome and save lives. By the statistics of our world in data, 6-8% of the world population has received at least one dose of COVID-19 vaccine. 13 billion dose has been administered globally, and 2.7 billion are now administered each day. 23% of people in low-income countries has received at least one dose. It is not acceptable, the situation globally. However, donation of the vaccine and the COVAX facilities for vaccine sharing scheme only offer the partial solutions. Korea, Japan, China has highest uptake rate of the first and second dose of vaccine. However, they experienced the new surge, the waning the antibody level after second dose, which accelerates the booster third dose, but the uptake rate is not high. Maybe that makes new outbreak in this foreign China, Korea, Japan. Among the countermeasures, the number of tests is a good index, but the opening of borders, the opening and the closing of school and the workplace, whether to allow the various events such as sports events, the number of people using restaurant, and the hour used are common measure of the NPI. Most of countries lift the restriction of their measures according to the high vaccine uptake rate, but only China contained his zero COVID policy, such as lockdown, shutdown, and contact trace, and mass survey. My answer, this current pandemic will be neither the last nor the worst global health crisis of the present centuries. That is my speech. But Richard Horton, editor of the Lancet, the chief editor Lancet, said May 2nd, 2020. IHR effect for global health security. My question is, as I mentioned, the Dr. G said already about the IHR. I focus only the effectiveness of the IHR. IHR 2005, in 2005, IHR was amended after the outbreak of SARS in China. The main change is from control of disease of border to the containment of source. Second, from the disease list to all acute public health events, from preset measures to adapted real-time response. And WHO has the power to declaration of the public health emergency international concern, which is associated with the traveling and the trade restrictions. WHO declare the pay based on the possibility of the serious impact to the world by disease and unusual events and international spread possibilities and significant risk for the international travel or the trade restriction. After the Ebola outbreak, WHO launched the World Health Emergency Program. They consist of the two pillars. One is the emergency preparedness, emergency response team. The other is emergency preparedness. These programs launched 2015. Now, this program may be do their best to contain the SARS outbreak. WHO survey the situation in each state, economic state, twicely after the outbreak. Almost nearly 135 countries involved in survey. 95% of the countries are disrupted their essential service programs. Only 9%, 6% of the countries report no disruptions. How did this country overcome these situations? In early stage of pandemic, China did shutdown, lockdown, and then Italy, France, UK, USA will also follow this the lockdown, shutdowns. By the IHR, there are some guidance for the response. The first one is adapt the rigorous scientific standard. And the second, to make decision transparent and fairly. And the last one is to adopt the least restrictive measures needed to protect public health. However, most of countries decide to implement the measures such as lockdown, shutdown, and close the borders. all countries violate the IHR, the Article 43. How WHO try to obey their recommendation and guidances? I think right now we need the powerful another the pandemic prevention treaty or the change the IHR, the fundamentals. My opinion is the world is not safer than the 25 by the regime of the IHR 2005. My question is, third question is, how we respond to COVID-19? Let's talk about the developed measures and what kind of the measures. This is the dynamics of the COVID-19. This disease is needed to the vigorous quarantines by the tests of PCR prior to symptom, because virus shedding from the 2.3 days prior to symptom, and the patient must be isolated for 10 days because the virus disappeared 10 days after onset of symptoms. So this approach developed the TTIQ, test, tracing, isolation, quarantine method. This method is similar to the 3Ts, Korea brand name 3Ts, the test, trace, treatment concept. 2050, the district health officers, health centers of Korea play main role of the 3Ts approaches. Theoretically, if more than 75% of contract will be quarantined, the effective reproductive rate number will be lesser than the 1 point. That TTIQ is very important approach to the early stage of the control the COVID-19. This is the early stage approach. The flattening the curve, epicurve in early stage might be due to the contact tracing of household, targeted tests of the PCR, quarantine and isolation to prevent the spread of virus. Treatment of positive cases according to the severity. Left side of the figures made by the UN report of the SDG by the Jeffrey Sachs professors in April 2020. The Korea is did the best to the testing the PCR. This may flatten the curve of appear. And and WHO recommended the behavior change, washing hands, wearing masks, and the coping etiquette. The behavior change TTIQ is the main tool, basic approach, early stage of the outbreak of the COVID-19. This is the second the approach to the NPI. Second approach is the NPI, non-pharmaceutical intervention. According to the sporadic transmission, localized community transmission, large-scale community transmission, we apply the two track. One track is a focused, stringent approach to the control of outbreak with minimal socio-economic harm in outbreak states. The other approach is the broad, stepwise approach in proportion to COVID-19 transmission based on the cost-benefit analysis. Roughly, in Korea, we early stage we applied the track 1, but the outbreak spread in the communities. We mixed track 1, track 2 the approaches. And last year and early stage of this year, we tried the second track, widely spread in the large scale approach to control the COVID-19. Second approach is the vaccinations. The vaccination is the single most important strategy to the countermeasure against the pandemic of COVID-19. The aim of the vaccination, first to reduce the mortality and the severe morbidity and the hospitalization. Second is to reduce the disease burden and limit the health system impact and begin restoring the economic activities. Last goal is to reduce the SARS-CoV-19 transmission and transmission in society. Target population are three groups. One is the highest risk group. Second is adults. Third is adolescents. Last approach is the primary health care approaches. In advanced countries, most of the COVID-19 controlled by the primary health care settings. The primary health care, the clinics has a function, the first contact treats and the coordinated treats and the comprehensive care compared to the Korea. Korea, the control, the most of the patient controlled by the health centers. Fourth question is, how are the public health response to COVID-19? The preparedness is the single most important. We had pandemic influenza 2003, 9, 10, the MERS 2015 and 18, which facilitated the strengthening not only the public health sectors but also the private sector and the communities. This scheme, National Crisis Scheme System, launched 2009 after the outbreak of the pandemic influenza. At the time, we developed the public health response system, the quarantine at border. In the COVID-19, we also recommend the institutional quarantine at early stage because of the home quarantine is not good for all situation, because the multi-generation in household and the small space of house. So in fact, household infection rate is 11 point, near the 6 times higher than non-household infection. It is the 2 points. This data support our decision of the institutional quarantines. Second stage, the public response is the early detection, contact tracing, test and isolation, TTIQ, as I mentioned about, I skipped this slide. And in the public response, we applied the triage system for the control of the COVID-19. In local government and local association, on April 2020, we had a huge outbreak on the Daegu area. At the time, the triage system applied to the outbreak. So all PCR positive case without symptom, with a symptom, to be the triage to prevent overflow patients to hospital of the private sectors. At the time, we developed the Quasi hospital, 18 Quasi hospital, total bed is 4,000. This portal, yes, this portal is our hospital in Seoul, and the other, the Quasi hospital in the Mungyong area, the hospital dormitory. We reconstructed the dormitory to the care of patients. This Quasi hospital is the main role in early surgery. But we developed a network of hospitals for severe case for the reducing the mortality. At surgery on the April 2020, we did not have good experience of the referral system for the patient from district to the provincial level and from provincial to the central level in severe case. Even though there is some communication channel between the hospital to the central government directory, it is hard to coordinate the hospital bed, IC bed, and respirator, health workers, including nurses and doctors. In the community spread level, we applied the behavior change, and also we used the 3 T's, and we applied the social distance scheme. We called it the BTS, the behavior change 3, 3T method, and the 3 kind of social distance measures. You know the BTS? You remember the BTS. But in surge, preparing the surge, on January this year, Korean government developed the algorithm for detection of the patients and the consultation for the primary care facilities, and the staying at home and home care policies. We introduced the rapid antigen tests in clinic, and the patients got the confirmatory diagnostic procedure by the PCR test on the health center or the screening centers. If no risk factors such as hypertension, diabetes mellitus, hypertension, the heart disease, they got the subscription by the simple fields of the flu medicine, but they have risk factors. They took fields of the antiviral drugs, and sometimes they refer to the district hospitals or the university hospitals. So more than the 10,000 of clinics involved this scheme for the preparing the surge. They care more than 600,000 cases for a day at March 16th. Vaccination of the immunities. We use as I mentioned about the vaccine is very important tool. So why is it difficult to reach the threshold, traditional the immunities, despite such the high vaccine uptake rate and the high case of the natural infections? Contrary to our expectation, the immune escape by the mutation is take place, and according to the cohort study, 56% of the patients infected during the spread to the Omicron variant has no symptom, asymptomatic, which make difficult to block transmissions. Since COVID-19 does not elicit the systemic immunities, permanent immunities like measles and the smallpox vaccination or the natural infections, does not maintain effect of the preventing infection for a long time. And lastly, the resistance against the intervention measures such as the vaccination or wearing mask is also believed to contribute to the ongoing spread of the ongoing spread of disease, prevention of disease. Therefore, vaccination is the only choice, but we are focused on the reducing hospitalization and prevent deaths rather than on the community transmission and eradication through the herd immunity strategies. I skipped. We had a high uptake rate, first dose and second dose, but third booster, first booster, so first dose is only the 15%. And in this fall, we are the campaign for the winter season. The uptake rate is only 1.6%. This reflects some resistance to the people to uptake the immunities. So I think we have the seventh outbreak in this force. Last, my question, can we make the world safer? This is the approach of the elimination or the mitigation the approach. Elimination approach in early stage, very good result for the save the lives and save the economies and the liberties. In our study, in the early stage of the outbreak and this year, we compare the relationship between COVID-19 mortality and the GDP loss. In early stage, the reverse relationship between the mortality and the GDP loss, but in this year, there is no the relationship between the COVID-19 mortality and the GDP loss. I don't know exactly the cause of but I think this is the early stage of the studies. I would like to recall the voice of the WHO. He said international cooperation on the vaccine equality last year. This slide, WHO chief urged heart booster shot for the rest of the years. I think we need more vaccine. No one is safe until everyone is safe. WHO, the facility to establish to the scale of the vaccination, but it is far from our goals. Solidarity and alliance is a very important subject. We hope to cooperate for sectors, other countries for the future. One sector is sharing the experience of the quarantine, screen testing, or border controls, outbreak data, and the bias characteristics. The sector two is clinical experience and the data exchange of the patient care. So the sector is research and therapeutics, vaccine and diagnostics, lab tested. Last sector is producing and stockpiling of PPE. I think Korea government expand their role to this solidarity and alliance. This is my last slide. Yes. In conclusion, in terms of the mortality and incidences, South Korea saved many lives by suppression policy through the behavioral change, social distance, and active tests, tracing, isolation, quarantine. The consequences of policy were all too obviously efficient healthcare systems, good leadership, citizens' participation, and protection of vulnerable peoples are outstanding. Based on this international cooperation and solidarity to end this disease should be strengthening in order to overcome this disease. The development of vaccine, diagnostic agents, and therapeutics are very important tools. Fair access to the vaccine is possible only when the R&D are carried out smoothly. In Korea, government try best to the R&D to support the other country and the scale of the vaccine and producing. This is my last slide. The pandemic is not over, but the end in sight. The Tedros said, we will move forward towards the goal of health for all. Together, learn from the past, we can change the future of the global public health. The late Digit Zhongli said, this is the slide. We try to forward toward the goal, eradication of the COVID-19. Thank you again.
네,
Thank you, Dr. Jonggu Lee. It was the presentation by Dr. Jonggu Lee from Seoul National University College of Medicine. He asked 5 questions in order to talk about our future direction of cooperation in the public health sector. Once again, please give a big hand to the presenters in our first session. So this concludes our first session, and we have a second and third session. And before that, we'd like to have a short coffee break. So it is 2:52 at the moment. We are going to have a short coffee break together with a snack at the lobby. So after your break, we're going to start our second session at 3:10. So after enjoying your coffee break, please come back by 3:10 to the hall, and please make sure you be punctual for our next session. Thank you.
저희 세션 2 이제 시작하려고 합니다.
Shortly, we are going to begin our second session. Please enter to the hall and make sure that you mute your cell phones for minimized interruptions during the conference. Now, within a couple of minutes, we are going to resume our session.
네, 어떻게 잘 쉬셨습니까?
Did you enjoy your short coffee break? Now we're going to start our second session of the day. Today, in our second session, we're going to talk about building cooperative system between ROK and ASEAN in the public health sector. In the second session, we have number of professionals to share their ideas. The first presentation will be made by Mr. Jung Tong-young, Director of the Division of Emergency Response from the KDCA. He's going to talk about Korea's response to COVID-19 and lessons learned. Please welcome Mr. Jung Tong-young to the podium. Please welcome him with a big hand.
네, 반갑습니다.
Hello everyone, I am Jung Tong-young. I'm in charge of Korea's response to COVID-19 at the KDCA. Today I'm going to talk about Korea's responses to the COVID-19 for the last 3 years, and also I'd like to share Korea's painful lessons learned during the pandemic. So I'm not sure if I could cover all these pages within 15 minutes, so I decided to speak in Korean in order to deliver as much information as possible. So first of all, I wanted to summarize the situation of the COVID-19 in Korea. Now we are going through the 6th wave. So in the early 2020, we experienced the first wave. So in a day, we had more than 9 million people confirmed. And it was one of the largest record around the world regarding the number of confirmed cases. And thanks to the first wave, we learned some know-how and we were able to deal with the second, third, fourth, and fifth wave. So compared to the first wave, throughout the second to fifth wave, we were able to have much less number of confirmed cases. And also from the fourth wave, we had Omicron variant. By and large, we had more than 17 million confirmed cases during this period. And from this summer, we are experiencing the 6th wave. So in order to briefly explain Korea's COVID-19 responses, first of all, in the early stage of the pandemic, we had a strong containment strategy because we did not understand the characteristics of the disease. So we applied special quarantine measures and adjusted the number of immigrants or travelers to Korea in order to manage the pandemic situation. And then our local community started to experience the infection. So in this phase, we adopted a suppression strategy because at that time, we experienced epidemic peaks. But despite these epidemic peaks, we wanted to provide a proper level of medical services to our people. So with a strong suppression strategy, we applied social distancing together with vaccination. And then together with Omicron variant, we switched to mitigation strategy. Rather than controlling the number of confirmed cases, but we wanted to minimize the potential damage to the victims. So we strengthened our treatment strategy during this period. So I'm going to talk about Korea's responses by different sections. First of all, test. Test is important, especially we wanted to detect the confirmed or suspected cases very fastly and in a timely manner. From the start of the pandemic, Korea was fast to respond to test the suspected cases based on accurate testing methodology and also based on our advanced diagnostic kit. We were able to test and detect confirmed cases on a timely manner in order to prevent any potential spread towards local community. And also, we wanted to increase the accessibility to the people who want to get tested so that whenever they want, they can visit laboratories or test facilities and get tested in order to make sure that they have no infection or they are infected. And also, there are the people infected without symptoms. For these people as well, proper testing will be the only measure to reduce potential spread or spread toward the local community. And also, rapid antigen testing was adopted. So only with the positive result from antigen testing, people were able to get treated in medical facilities. You must be familiar with drive-through and walk-through facilities, which is quite innovative. And this innovative methodology was also helpful. Why these measures were possible in Korea? Because the Korean government already experienced the MERS and understood the importance of testing methodology. That is why we invested a lot in testing methodology development. And in order to develop the methodology for testing, we newly developed testing methodology for new 16 pathogens. And with the application of emergency drive-through facility, we were able to test and detect suspected cases in an earlier stage than other countries. And also, these testing kits were distributed nationwide on a timely manner. At the same time, private companies put investment into the development of vaccines and testing kits, and all these costs were covered by the National Health Insurance Service. What's also important is cooperation with the private sector, not only with private companies, but also with academic society. We wanted to upgrade our collaboration so that we could develop innovative methodology and innovative techniques. So as you can see in the slide, in January 2020, we started to have EUA process. And within 10 days since the adoption of EUA policy, we were able to approve these new products in an emergent manner. And this shows how fast Korea's testing capacity scaled up. In the earlier stage, we were able to test only 2,000 people. But in February and March, we upgraded the number to 20,000 and even 50,000 in March. At that time, with this scaled up capacity, but the number of confirmed cases was less than 5,000. So our capacity to test in suspected cases was very effective because the number of actual confirmed cases at that time was not that big. Based on these capacity, if you take a look at the orange-colored diagram, this shows how our capacity for testing increased. And this blue-colored diagram shows the actual number of testing for a day. So during this pandemic period, always our capacity for testing exceeds that of the confirmed cases. And I think this is an important part in Korea's response to the pandemic. And according to Australia's Doherty Institute, epidemiological investigation and TTIQ are so important. So when we partially adopted TTIQ or optimal TTIQ was adopted, there are a huge difference. So with the partial TTIQ, if there's social distancing and other social isolation measures are adopted, then a proper level of epidemiological survey and epidemiological measures could be applied. However, if other measures are not working, we need to adopt more stronger social distancing measures. So from the point of entry, we tried best in order to apply best quality of quarantine policy. And together with local community, the central government organized emergency teams so that we could make swift actions. And also in order to support our patients, we developed mobile applications and encouraged patients who are staying home to download this application and get informed about the disease. So according to some survey conducted in other nations, the self-quarantine measures was kept only 50% in other nations. However, the ratio is much higher in Korea thanks to these mobile applications, I think. And also according to national disease control law and regulations, we also reviewed credit card usage and mobile phone usage record. And all of these were possible based on our legal framework. And also based on this credit card transaction record, we were able to find out who visited a specific restaurant for a specific period of time. And also, in order to side effects from vaccines and treatment, on a real-time basis, we were able to monitor what kind of medicines were prescribed to patients. This was also possible because in Korea, electronic medical record was adopted already. So by taking advantage of the existing system, we were able to track the previous route of visited countries, etc. And according to the epidemic trend, we were able to mobilize human resources on a real-time basis. I'd like to explain further about human resources later on. So thanks to these strong measures, I think we were able to establish this 3T strategy more effectively. And after the Omicron variant, we optimized the human resources mobilized into the prevention measures. So all these were possible because after the outbreak of MERS, the Korean government revised the relevant regulations and laws and successfully nurtured specialized epidemiologists. And also, we were able to collect private information on a broader manner thanks to these regulations. And medical institutions or testing institutions were supposed to record and report the testing result on a real-time basis to the central government thanks to these regulations. And the cooperation between the central government and local community was also effective. So based on guideline and unified protocol, local communities followed their actions based on these structure. And also the participation of citizens was good enough. Unfortunately, these were not translated into English, but how the epidemiological survey was made was summarized in this diagram. So the government can collect mobile phone usage or credit card transaction record for the purpose of epidemiology survey. So our epidemiological investigators have been nurtured since the outbreak of MERS. Because at that time, we had only 34 epidemiologists nationwide at the early stage of MERS. So at that time, we didn't have enough number of epidemiologists in Korea. But thanks to the revised regulation and laws, the central government has to have at least 30 epidemiologists. And also local community has more than 100 epidemiological lists at the moment before the pandemic. And then since 2019, today we have almost 218 epidemiology investigators. So it was thanks to the revision of our relevant regulation. So thanks to the revised regulation, the local community became supposed to have at least have more epidemiologists. So whenever we adopt a new strategy and new policy, if we have legal framework back at the background, then we can strengthen our implementation. So during the pandemic, we had a special hospital beds only for the COVID patients. So the national hospital or national medical institutions focused on COVID-19 patients and monitor their symptoms. And the government acquired a variety of medicines and therapeutics, and also developed therapeutics at the same time. And in addition to general hospitals, we wanted to add National Treatment Center and other specialized facility. We renovated existing facility like university dormitory so that we could expand the number of beds for COVID-19 patients. And Korea has not. In Korea, remote medicine is not legal at the moment. However, just for the emergency purpose, Korea revised remote medicine possible for COVID-19 patients. And also for those who are staying home, and especially for the aged people, the medical institutions made a couple of calls a day in order to check the symptoms and health condition of those victims. And if there is any issue, on a swift manner, these medical institutions will connect the patients so that a swift treatment could be provided. And in local community where medical service is not enough, then nurses and doctors in the national pool will be dispatched to support the relevant local community. So these kind of medical responses were possible thanks to our experience from the MERS. We were able to establish our medical infrastructure more faster manner, and also we expanded the number of hospital beds that are managed by the national medical agencies. And also we have invested in our preparation for potential public health emergencies. So in the past, some said Korea has too many hospital beds. However, during this emergency situation, this excessive number of hospital beds were helpful. And also the intensive care unit was also helpful. And the contribution and devotion of medical service providers were also helpful. And according to our triage, we provided differentiated treatment. For severe cases or moderate cases, we have differentiated facilities where the differentiated and more effective treatment would be provided. And for the severe cases, the medical institutions made calls to the people who are staying home for their quarantine. I think this is one of the measures that were most effective in Korea. So at the end of 2019, before it was spread to local community, at that time we had the bed for ICU, about 6,000 ICU beds. And then we increased the number to more than 25,000 with the advent of Omicron variant. So in addition to public hospital beds, we wanted to use private hospitals beds as well for the purpose of emergency care for COVID-19 patients. So in the earlier stage, we utilized the public hospitals and then expanded the system toward the private hospitals as well. And vaccination is important too. Of course, Korea was not the first country where vaccination was started. However, the government was able to acquire the vaccines on a timely manner. And for large-scale vaccination, we installed 280 vaccination centers around the country. So in total, we had 17,000 vaccination-related facilities. So in a day, 2% of total Korean population were able to be vaccinated. Because in other countries, the ratio is only 1%. Compared to 1%, this 2% is pretty impressive. And local communities and medical centers also made a variety of efforts in order to encourage vaccination among the elderly citizens and foreign workers working in Korea. Compared to other countries, Korea strengthened our monitoring system toward any side effect from vaccination. And the whole process of vaccination has been updated on computers so that everyone can share the information. In Korea, this red mark representing Korea. So we were not the first country where vaccination started. However, Korea was the first that reached 70% of vaccination among its people. Because Korea has managed a national immunization program for a long time, I think this national immunization program also contributed to this high percentage of COVID-19 vaccination. So without complete lockdown and restriction on movement or travel, we wanted to encourage social distancing. And one more thing I'd like to share is that we tried to lift social distancing last year, December, and then within a month, we resumed social distancing measures because at that time, this lifting social distancing was too fast. Because at that time, the ICU beds were occupied up to 80%. And based on this data, we decided to go back to social distancing. So we have 4 grades of governance regarding public health situation. So according to each level, the competence authority will be different. The Ministry of Health and Welfare and KDCA and also the Prime Minister will be in charge according to different levels. And one of success factors in Korea is that we adopted pan-governmental approach. Under the leadership of Prime Minister, all the ministries and the heads of provinces nationwide were gathered every day. And then after a while, we reduced the number or frequency of that emergency meeting to 3 times a week. But thanks to these emergency meetings under the leadership of Prime Minister was very helpful in our response towards the pandemic. So Korea has multiple legal framework. One of them is a Disease Control Act, and we have made many amendments to this act according to new diseases, including MERS and COVID-19. In 2020, the KDCA, which was just a division, has upgraded to agency. So difference, the KDCA used to be a part of the Ministry of Health and Welfare. That's why we used to have limitations on human resources and budget, but with our upgrade, with being upgraded to agency, now we have more human resources and more budget to mobilize. With that, the KDCA has authority to implement the relevant regulation. So today we have 6 health-related laws in Korea. For these 6 laws, KDCA will have the authority to enforce the implementation of these laws. The guidelines and recommendations based on the laws will be binding for local communities. I think this is the biggest change after being upgraded to agency. Budget-wise, after the COVID-19, we expanded the amount of budget very fast. So today we have almost 5 trillion won for disease prevention and control. And communication is very important. Throughout the MERS, we learned the importance of transparent information. And in order to deal with fake news, we promoted many public campaigns and many information sharing campaigns. But before Omicron variant, we didn't have that many confirmed cases. So we didn't. We were able to avoid the most serious period where the mortality rate was the highest. However, in the face of Omicron variant, the mortality rate increased in Korea as well, which is quite regrettable. And there have been some collateral damage and also social and economic damage too. So these Korean measures were included in many reports published by international agencies. So now I'd like to share some lessons we learned throughout the COVID-19. So swift initial response and initial strategy development were effective. And we were able to secure our ability to conduct epidemiological survey in an earlier manner. And also with these measures in place, we were able to reduce the level of social distancing. However, we did not have a high-quality online system in the beginning. That's why we spent a lot of hours or time to establish this online system to monitor large-scale outbreak. But thanks to the abundant investment in medical infrastructure after the outbreak of MERS, we were able to reduce our response time in the initial stage. Not only the accessibility to vaccines and treatment, we need to make sure the collateral damage is minimized. And one of the takeaways we should remember is that the cooperation with the private sector is important, especially for a country like Korea, where the private sector plays a huge role in our medical system. So with a strong cooperation with the private medical sector, we were able to swiftly scale up our efforts to prevent and control the pandemic situation. And just please read through these lessons by yourself. And based on these lessons, we will continue to update our strategy. And also, we're going to establish integrated data system and also make upgraded diagnostic systems so that we could detect any potential variant on an earlier manner. And also, we're going to have more aligned systems. So in many areas, we need to make supplement efforts. And also, going forward, we need to be more evidence-based. And also, for long-term care facilities, we need to make further efforts. So by and large, we need to upgrade our governance for these medical systems. And there have been many controversies over Korean version of social distancing because in the course of social distancing, small businesses struggled a lot. Due to social distancing, they were not able to run their businesses normally. And the Korean government had a prolonged period of social distancing. But over this prolonged period of social distancing, there have been many controversies. This picture here is the building of our agency. This represents Dandelion. However, it looks like COVID virus. We have 3 sculptures like this. So we believe that one of them represents SARS, and one of them for H1N1, and one of them is for COVID-19. Thank you for your attention. Thank you, Mr. Jung Dong-myung, for your kind presentation. So as we have a tactic schedule, he has had to accelerate the speed of his presentation. Now, we have Ms. Kim Soon-hee.
So please welcome the Kim Soon-hee from the Korea Foundation for International Healthcare.
Kim, Director General of Research and Training Innovation Center of the KOPI, Korea Foundation for International Healthcare. 벗어도 돼. Because of behind time for the presentation, I will give you a short introduction of KOPI and other ASEAN-ROK healthcare partner institutions and their projects. Let me start from the overview of KOPI. Here is the picture of Dr. Lee Jong-wook, who was the 6th Director General of WHO. The KOPI is a public agency under the Ministry of Health and Welfare of ROK. We mainly provide ODA to partner countries, health assistance to DPRK, overseas Koreans, and migrant workers in Korea under the law. This is our vision and mission, is to be a development cooperation agency promoting global health with mission here. KOPI has been playing roles as a global partner to strengthen the capacity building in various healthcare systems in Asia and Africa. Major projects are improving primary health care, promoting maternal, neonate, and child health, and strengthening capacity of healthcare professionals, and national infectious disease control, and so on. In particular, there are projects implementing in Laos, PDR, Cambodia, Myanmar, and Vietnam among ASEAN member states by KOPI. Now I'm moving on ASEAN-ROK cooperation projects and institutions. As seen in the left side, there is ASEAN-ROK Summit has been held since 1997. In 2020 and 2021, Korea shared COVID-19 vaccine with ASEAN member states. In addition, the ASEAN Plus 3 Health Ministers Meeting, HMM, China, Japan, and Korea have been hosted since 2004 to discuss cooperation, and in prior senior official meeting, Zoom HD. To strengthening health systems through comprehensive cooperation project with ASEAN, Korean Ministry of Health and Welfare submitted 2 concept notes with the theme of Universal Health Coverage UHC and Health Security. To achieve the goals, ASEAN-ROK Healthcare Partnership Task Force developed 5 projects under 2 thematic areas in periods of 2021 through 2023. In 2020, the Ministry of Health and Welfare established ASEAN-ROK Healthcare Partnership Task Force to develop specific cooperation relations with ASEAN. Since then, KOPI has played the role of secretary, which is in charge of overall management, operation, and communication with ASEAN. As a secretary, I will introduce each partner institution's project. First, National Health Insurance Service, NHIS, is the single insurer of the Korea, is operating National Health Insurance, NHI, that protects the risk of disease and long-term care support. NHIS collects insurance contribution from the insured residents of ROK to support their healthcare benefits. Co-payments were provided upon using the service. After utilizing healthcare services, providers submit claims to the Health Insurance Review and Assessment Service, HIRA. They review and share results of the review each claim to the NHIS. Based on the result, the NHIS make payments to healthcare providers. That is the schema of national health system in Korea. The National Health Insurance Service is conducting an ASEAN Adaptive Financial Risk Management System Support Project. Many countries, including ASEAN member states, are facing financial challenges due to rapid increase in healthcare expenses, high out-of-pocket expenses, etc. This project supports establishing a data-based financial risk management system to help the ASEAN member states overcome financial challenges. It aims to strengthen the health-specific financial stability, support evidence-based policy decisions, and maximize financial management efficiency. From last year, NHIS analyzed 10 Asian member states and conducted pilot consulting in 3 countries. The NHIS will select one ASEAN country to design a financial risk management model next year. This model will have the financial situation and make a quick decision through a graphical dashboard to understand financial situation at a glance. In the middle, the screen layout of the target model here. In addition, the NHIS will conduct various activities such as working level staff training on UHC and National Health Insurance System, and workshops related to the use of system in the target country. Next is Health Insurance Review and Assessment Service, HIRA. HIRA was originally established as a claim review organization and started to review benefit claims since 1988. These are their main activities and roles. HIRA, as a national medical assessment agency, is putting the best efforts by conducting fair review and assessment and ensuring high-quality national health insurance service to give quality of medical care in Korea. HIRA is conducting establishment of ASEAN e-government cloud system for infectious disease response under this umbrella of the projects. The main purpose of the projects are establishing a system that can prevent, detect, and respond quickly to the threat of healthcare, especially for the infectious disease. The second objective is, with cooperation with the AMS, the HIRA intends to share experiences and approach in response to infectious disease. It is expected to the system that will be enhancing resilience of AMS capacity. As such purpose, in 2021, a feasibility study was conducted and analyzed healthcare status and ICT environment in terms of DUR, PIS, by evaluating the urgency, preparedness, and impact of each country. The HIRA selected 4 priority partner countries, which are the Philippines, Cambodia, Vietnam, and Indonesia, and currently cooperating with Cambodia and the Philippines. This year, the HIRA is focusing on a pharmaceutical information system, PIS, and conducting a consultation for both countries to move on next step to establish the system in 2023. Next year, the HIRA will conduct 2B model for business processing re-engineering BPR and information strategy planning ISP for the priority country, and then we'll be customizing and analyzing the system to monitor the use and distribution of drugs, which will be redesign a pharmaceutical business process by using the drug code, standard, and information of a PIS. Next, the Korea Human Resource Development Institute for Health and Welfare, KOHAI. The KOHAI is a human resource development organization under the Ministry of Health and Welfare to improve quality of planning the development of health and welfare area, implementing the education and training programs in diverse personnel. The purpose of the training is, the KOHAI is organizing this symposium and conference. The purpose of the training is to achieve sustainable UHC in Asian countries by strengthening the capacity of Asian health personnel. It aims to strengthen problem-solving skills of the AMS in achieving UHC, and has reflected the various needs of each AMS as designing the Asian customized UHC international training course, which is now we are participating. Those are pictures of training in 2021 and 2022. Unfortunately, during the course last year, we had an online course only. But this year, finally, we met together. So next year, the KOHAI will provide training to maximize achievement of our business objectives. So finally, the Korea Health Promotion Institute, KHEPI, in Korea, health promotion has become one of the most important parts of healthcare since the National Health Promotion Act was enacted in 1995. The KHEPI was established in 2011 and has been working on development and support the national health promotion policies, technical assistance, consulting of national health promotion programs, building digital capabilities such as IoT-based elderly health management, and strengthening global cooperation network with international health promotion institutions. The KHEPI is conducting international strategic cooperation project between the Republic of Korea and the ASEAN. It aims to establish an ASEAN-ROK cooperation system in health promotion area, so-called K-Health module, under the mission to improve quality of health and medical system in Asian member states. This year, the KHEPI assessed health priority and demands of the ASEAN member states by conducting health priority survey, series of in-person interviews, and case analysis for developing ASEAN-ROK health cooperation comprehensive strategy. This project will continue next year as well. So we hope all these 5 projects to be successfully implemented and continued ROK ASEAN partnership in the long term. Thank you for listening, and I hope to have a very brief introduction of all our projects. Thank you.
네, 고맙습니다.
Thank you, Ms. Kim Soo-ne from Kohai to talk about K-Health strategy and K-Health cooperation project. I look forward continued cooperation from K-Health as well. Now we have Mr. Fernando from ASEAN Secretariat. He's going to talk about ASEAN's collective response to COVID-19 pandemic. Please welcome him with a big hand.
Good afternoon, honorable guests and distinguished representatives. Thank you. Deepest appreciation to the Republic of Korea through the Ministry of Health and Welfare and related agencies such as the KDCA and KOHAI for inviting ASEAN member states and ASEAN Secretariat to this timely event. Good afternoon, and Joyun Ohyeyo. Apologies, I tried. Allow me to share with you a brief overview of the collective response of ASEAN to COVID-19 pandemic and other health threats. Allow me to present the COVID-19 situation overview at the global and regional levels, including other diseases such as monkeypox in the next 6 slides. I'll try to be fast and present all of these things in less than 15 minutes. Other information included in this presentation of mine, as well as this report, are listed in the table of contents that are projected. The information have been obtained from various sources consolidated by the disease surveillance platforms of the ASEAN Biodiaspora Virtual Center, or ABVC, which is currently supported by the Global Affairs Canada through the Mitigation of Biological Threats program. The ABVC produces the situation report on relevant health threats in the ASEAN region 3 times a week since January of 2020. Reports are posted regularly in the ASEAN website and at the ASEAN portal for public health emergencies. Please be informed that KDCA will also be having exploratory discussions on possible cooperation areas with the proponents of ABVC together with the ASEAN Secretariat. Included in the situation report in the ASEAN region by ABVC are updates on travel advisories and travel requirements. There is also reporting done on the international travel routes with hotspots of infectious diseases. However, these are not included in this specific slide. This is still part of the travel advisories that was presented in the previous slide. At the ASEAN region, there were more than 35 million total confirmed cases with more than 360,000 deaths as of November 18 this year. The case fatality rate of ASEAN plus 3 or ASEAN member states ranges from 0.1 to 3.1%. Just to level the understanding, the case fatality rate or ratio is typically used as a measure of disease severity and is often used for predicting disease courses or outcome, where comparatively high rates are indicative of relatively poor outcomes, and it can also be used to evaluate the effect of new treatments with measures decreasing as treatment improves. The situation in the ASEAN region, as reflected in this slide, also reflects the global situation with a similar situation with regard to total cases and deaths, particularly during the situation of the Omicron variant surge. The COVID-19 Outlook Assessment, which is part of the ABVC situation report, also shows the following. Number 1, there are large proportions of high-risk population in all ASEAN member states that have been fully vaccinated. 2, ASEAN member states have large populations with immunity to COVID-19, either due to actual infection or vaccination. And number 3, ASEAN member states also continue to record infections either higher than the benchmark case of 10 or less cases per 100,000, and which may be continuously influenced by the Omicron variant. This COVID-19 outlook presents that while the situation has improved and subsequently restrictions have been eased in some countries, there is still a critical need to, first, sustain vaccinations, especially in hard-to-reach population or hard-to-reach areas or vulnerable populations. And second, sustain public health and social measures to further control COVID-19 transmissions and avoid complacency among populations. These vigilant responses will facilitate further the safe reopening of economies in the communities of ASEAN. This particular slide reinforces the vaccination information from the COVID-19 Outlook assessment that was previously shared. The ASEAN member states are continuously conducting vaccine rollouts to achieve the vaccination target of at least 70% of the population by mid-2022, as previously appealed by WHO. The 70% target is marked by the yellow vertical line on this particular slide, with the blue bar indicating the cumulative vaccination per ASEAN member states. This slide signifies that a large majority of ASEAN member states have already reached more than 70% of cumulative vaccinated populations, and all ASEAN member states are working towards higher percentage of populations with booster doses. Hopefully, our region will be able to move further towards having greater number of population with full vaccinations and boosters through our collective efforts. There is also a continuous surveillance of other emerging diseases in the ASEAN region, which is also included in the ABVC report. This includes the emergence of monkeypox in the ASEAN region, where 38 cases have been recorded so far. Initiatives on this matter include the one-off procurement of antivirals and vaccines for monkeypox through the use of the COVID-19 ASEAN Response Fund, wherein this fund has the contribution of ASEAN member states as well as other external partners or dialogue partners, including Korea. On other related non-health matters, the following are shared based on the situation at this time after the height of the pandemic situation. The GDP, which was also elaborated earlier by our distinguished speaker from KDCA, is expected to grow and recuperate by 5.1% in 2022 and 5.0% in 2023 as the region continues to reopen and recover from the pandemic. Total trade values in 2021, which is around $3.3 trillion US dollars, exceeded the pre-pandemic level in 2019, which is 2.8 trillion US dollars. Although intra-ASEAN trade stood at 21.3%. In Q1 of 2022, total trade values was at $731.3 billion US dollars. Intra-ASEAN trade recorded at 24.7%. The foreign direct investment into ASEAN increased by more than 42% in 2021 to $174.1 billion US dollars. This is slightly below the 2019 level. Preliminary investment inflow noted in the first quarter of 2022 at $50.2 billion US dollars surpassed year-on-year level investments inflow recorded in the first quarter of 2021 at $45.5 billion US dollars. So trade in 2021 was geared by, number one, electrical machinery and mineral fuel sector, while investment in 2022 was driven by services and manufacturing sector. So in a nutshell, in a summary, the ASEAN region is slowly progressing towards recovery from the multifactorial impacts of pandemic. Focusing on matters specific to the ASEAN health sector, The ASEAN health sector has continued to implement 25 health-related initiatives which have been synergized, scaled up, and strengthened in responding to COVID-19 and in preparing for future public health emergencies. The ASEAN health sector, through the support of the ASEAN health ministers and also as elaborated in the adopted ASEAN Summit Chairman Statement, which was recently hosted by Cambodia, have also elaborated on the need to focus on responding to all hazards and emerging threats, which is one of the cluster priorities of the ASEAN Post-2015 Health Development Agenda. In particular, there is a need to focus on health priorities, particularly activities that are related to regional preparedness and response to public health emergencies. However, based on the health priorities of the ASEAN health sector, there are inter-cluster or priorities that needs to be interlinked, network, and coordinated with, simply because the response to COVID-19 pandemic does not only involve one particular initiative, but also multiple initiatives, which is also shown in this next particular slide, wherein 25 health-related ongoing and completed activities have been scaled up and synergized and harmonized, not only within the health sector, but also with the rest of the non-health sectors. Some of these listed initiatives will be elaborated in the succeeding slides. One would be in terms of the ongoing initiatives in the development of the ASEAN Public Health Emergency, ASEAN Center for Public Health Emergencies and Emerging Diseases, or ACFID, wherein during the 15th ASEAN Health Ministers meeting held in May 2022 in Bali, Indonesia, the ASEAN Health Ministers tasked the SOMHD to finalize the establishment agreement of ACFID by September. However, due to a lot of discussions with regard to detailed elaborations and revisions of the various articles of this establishment agreement, which were conducted in July, September, October, the final establishment agreement has not yet been fully set in stone, and as such, further follow-up discussions will be made through an in-person meeting, primarily among the 3 host countries, Indonesia, Thailand, and Vietnam, to be facilitated by our current ASEAN Health Sector Chair, Lau PDR. So allow us to emphasize the following agreements as adopted by our ASEAN Health Ministers meeting in May of 2022. There is one, ACFID, with the functions of the pillars in its scope of work to be under Vietnam for the prevention and preparedness, under Indonesia for detection and risk assessment, and under Thailand for response. There will be one strategic plan, one monitoring and evaluation system, one governing board, and one establishment agreement, as mentioned earlier. The Secretariat Office, which had its soft launching in 2 or 3 months ago, is located in Thailand. The following slides would show the various scope of work of ACFID, which comprises of 3 major pillars, which includes preparedness and response, detection and risk assessment, and the scope of work on response, and other overarching themes such as information sharing and analytics, capability building. And this scope of work will be the basis of the functions of the ACFID. There would also be initiatives that would support the coordinating functions of ACFID, such as the ASEAN Public Health Emergency Coordination System. And this particular framework or system is currently being developed through a consultative process that would support the regional coordination of all stakeholders that would be engaged in public health emergency response. Together with the other 25 health-related initiatives for COVID-19 response would be the initiatives on the ASEAN vaccine security and self-reliance. This particular initiative on AVSSR implements the ASEAN Summit Declaration on AVSSR adopted in 2019. This slide presents the regional strategic and action plan on AVSSR, which are currently being implemented by the ASEAN member states. Also supporting the 25 health-related initiatives would be the various initiatives related to health security interface, which is the mitigation of biological threats program. And this would also support the initiatives on COVID-19 response, which would include laboratory strengthening, disease surveillance strengthening, as well as networking on Emergency Operations Center, which will be reported later on by my colleagues. Supporting the post-pandemic recovery would be the ASEAN Comprehensive Recovery Framework. And this would include initiatives on 5 broad strategies that would include health and non-health sectors. The first broad strategy would be on enhancing health systems. And this would support, this ACRF would support comprehensive recovery initiatives that would facilitate the slow or progressive opening of our economies. And second to the final slide would be the other initiatives related to supporting the initiatives of the health sector involving the non-health sectors with regard to the provision of a framework for a travel corridor arrangement, as well as the earmarking of the ASEAN regional supplies for medicine that would be needed in terms of responses to community needs against COVID-19 and other public health emergencies. These various initiatives would guarantee stability in providing essential goods and would facilitate seamless travel during COVID-19 pandemic. And these are all shown in the slide. As part of the ways forward, and based on the lessons learned, allow me to share with you the 4 points as projected. Number 1, there is really a need for multilateral partnership, and this is essential, especially amidst the lessons learned from the ASEAN COVID-19 Response Fund, and also in our recovery efforts, wherein it would include a response to all hazards and other emerging health threats. There should also be a renewed emphasis on stakeholder engagement through entry points of cooperation within the ASEAN mandate, as well as architecture. And there is a need to really focus on a whole of ASEAN and whole of community approach. It was mentioned by our previous distinguished speakers that this is not only a health crisis, but a crisis for all communities, a crisis to be engaged by all sectors. And there is also a need to be mindful of other emerging challenges as listed in the slide. But more importantly, allow me also to share with you the emerging challenge of societal complacency. Now that we are slowly responding to COVID-19 through a series of vaccination, our behavior modification should not be complacent so that we would fail in our personal protection against the transmission of infectious diseases. With that being said, thank you very much for your kind attention.
Thank you very much.
Thank you, Mr. Fernando, for your meaningful presentation. Now we have the last presenter for our second session. Now we're going to talk about each ASEAN country's response toward COVID-19 pandemic. So today we have presenters from Thailand and Malaysia. From Thailand, Public Health Laboratory Network. We're going to invite a presenter from Thailand.
위왓 원장님께서 Regional Public Health Laboratory.
So, based on the Regional Public Health Laboratory Network, the presentation will be given.
Good afternoon, everyone. I am Dr. Ashwin Lojanaviwat, the Director of the National Institute of Health of Thailand. Today, I would like to say thank you to the organization that you invite me for presentation today. And my topic is about the Regional Public Health Laboratory Network, or we call it the RPHL network, that developed by my institute. For the history of the RPHL network, the Thailand by the Department of Medical Science, Ministry of Public Health, as the leader in establishing a public laboratory network named the Regional Public Health Laboratory Network, we call as a RPHL. In 2019, under the Global Health Security Agenda, or GSSA, funded by the USAID through the FHI 360, the network was successfully formed and has functioned well since its inception, which aimed to share information, knowledge, and resources among human health, regional public health laboratory in Thailand also, and in the network. The network currently consists of 11 country members, including 10 countries from ASEAN, and also we have another one from Nepal. The function of the RPHL network and initial phase between 2020 and 2024. We will have 5 functions, which is enhancing communication, coordination, and collaboration, linkage for encouraging partnership and collaboration, sharing knowledge, information, and resources, providing an e-learning platform, facilitating capability building. The RPHL Network Secretariat Office housed at the Department of Medical Science in Thailand. Like you can see my office in the picture. And for the Secretariat team, right now we have the function of 4 of Secretariat team by me and Dr. Athiwat, Ms. Parishat, and Dr. Don Changsom. And the achievement of the program of the RPHL network during January 2020 until December 2021. By the first one that we achieved about the first enhanced communication and coordination, that we had to identify the contact person for member and key partners, and we have regularly conduct video conference every 2 months, every year, every 2 months for the RPHL network member and partners. The second, we promote the systematic document experience sharing among members. Everyone can see the RPHL network website that I already post in this one. We call the rphl.net, and then we review the document and upload them to the RPHL network website. And for the capacity building to respond to COVID-19, we conduct video conference for member discussion and place technical issue proposed by the member. We discuss a lot for many times via video conference. We developed the local online course for training COVID-19 specimen shipping in Thailand. It is a big conference that when we had to transfer the specimen, we should have a concern that it should be have a safety for everyone. And then we conduct online training on COVID-19 specimen shipping between Thailand and Malaysia, and also the Singapore They pull the laboratory expert on the website. Like now, we have more than 30 experts that everyone can direct contact. We conduct the tabletop exercise on the disease X. This is like a simulation exercise to prepare before the outbreak of the investigation. We pilot the Global Leadership Laboratory Program in Thailand. This is a training course that we already transferred by the WHO team, and we try to pilot the training for the executive member in Thailand. We also play the role as the implementing arms of GHSA Detection 1. Detection 1 is focused on the laboratory system and the other regional activity with strong public health, the laboratory network with active participation for member and partner to enhance communication, collaboration, and coordination. And we also implement activity for the mutual benefit for the country with strong support from the key development partner and donors. This program for RPHL network are flexibility and minimal bureaucratic process. The ability of the network with other lab network in other regions and strong government linkage to nominate two contact person for each country, identified in 11 member countries. And for availability of pooling laboratory experts, we have many areas of the experts, such as biosafety and biosecurity. For the area of quality management system strengthening, we have many biologists. We have many of molecular genetic and advanced technology. For the specific pathogen like virus genomic for influenza and SARS-CoV-2 variants, and the other high-risk pathogen. And also we have a laboratory and field investigation of hemorrhagic virus. And for the RPHL network, for the challenge among the member, we have many of the level of member participant is vary from each country. Someone they are expert in some area, but someone they cannot follow. So we had to try to help together via video conference. Competition with the other national agenda during the COVID-19 situation, when we want to set up the conference and everyone have busy by themselves. So we had to try to find the times. And for the rotation and promotion of the contact persons, we will find many things, many people. Someone they can work, someone they are promoted to be higher, and we had to have a contact person. And also during the COVID-19 situation, the travel was less strict during the lockdown policy. And for the secretariat, we have found some we had to ask someone for the new team. The workload of the responsibility of the team, the limit capacity for the network operation, and the secretariat is driving force for the network. And for the challenge of the capacity building, we have the limit of funding and collaboration with partner, and we need a Q&A platform to serve the players issue during the work. And for the website, we need further improvement, the webmaster to support the team, and upgrade to be classified member and non-members. And for the resource, we still don't have any funding, direct funding. It is the uncertain funding. It has to rely on the external funding. So the status of the network to build the funding. And for the governance, we should have a good functional governance is required. And also we had to make a long-term plan. and what is the next in the future to develop the RPHL network strategic work plan during the year 2022 until 2025. Like now, last month, we already have the face-to-face meeting that enhanced RPHL network partnership meeting on 18 to 19 October in Thailand. And the key development partner, including the Global Fund, WHO, CRO, the Foundation for Innovative of New Diagnostic, we call FIND, the Clinton Health Access Initiative, WOAH, USAID, TUC Thailand, and also we should have a video conference 3-year work plan consultation on 4 and 7 of November this year. The internal discussion will be among the members, and the result of the discussion or the work plan I will show you next. This is the RPHL network strategic work plan between the year 2022 and 2025, which is the goal of the resilience of laboratory and diagnostic system for improved health and outcome in Asia Pacific region. And with the mission of the RPHL network, we provide support to members in strengthening national laboratory system and diagnostic system for the timely detection of pathogen with the outbreak potential. And also, we will driving through the 4 strategic objectives. The number 1 is the strengthening for the foundation of secretariat with the development of business plan for RPHL network governance, communication, and long-term plans. And for the strategic number 2, to facilitate the capacity building, like we had to do the conduct gap analysis. We develop the capacity building plan. We promote the use of roster of the lab experts, and we twinning the program South to South cooperation by NUS RPHL network. We had to training the opportunity for GLLP, such as this one. And the third strategic objective about the strengthening of the network and coordinating platform. We had to promote the member ownership. Everyone should be the owner of this network. We organize an annual partnership forums, and also we enhance the network visibility. And the last one of the strategic objective should be about the enhanced knowledge management platform. This is a very focused for everyone. When we talking with the expert, we had to facilitate information and sharing learning platform by the member and partners. We conduct regular video conference every 2 months like now, and we develop a web-based platform for sharing the knowledge. Everyone can access to the website. And for the recommendation for the sustainability in cross-cutting trade that connect and underline for this core 4 of the key message. When we work together at the network, the first one should be we had to building the trust. Everyone had to rely together. The number 2 should be visibility, communication, and coordination. And the number 3, the network should have a governance and structure. And also for the last one, with the resource mobilization. And this is my key recommendation that I would like to message to everyone when we work together. And for the last one, I would like to say, when we work together at the network, is the key message to everyone that we should be never leave anyone behind. Thank you. We should move together. If you have any question or any any comment, I would like you to direct contact to me by the email that I will post later. Thank you so much.
네, 고맙습니다. 이렇게 해서
Thank you very much, Dr. From the PHAIL network. And we have the next speaker from Malaysia.
Dr. Tilaka Chinaya will talk about ASEAN EOC network. Let's take a look at the video.
Very good day to everyone. First of all, I would like to thank the organizer, the 2022 ASEAN-Korea International Conference on Response to Infectious Diseases, for inviting Malaysia, the lead country for the ASEAN EOC network, to share the activities that been carried out. So I am Dr. Tilaka Chinaya, the Deputy Director of Disease Control Division from Ministry of Health Malaysia. Would like to continue this presentation. And first, let me start with the background of this ASEAN Emergency Network for Public Health. The ASEAN EOC network was established to meet the International Health Regulation 2005 under Article 13, which requested the state party to develop, strengthen, and also maintain the capacity to respond promptly and effectively to any public health emergencies of international concern. And also this ASEAN EOC network is initiated as part of the regional surveillance and response mechanism that would enhance early detection and response among ASEAN member states in effectively managing the public health emergency and crisis. This ASEAN Emergency Operations Center was endorsed by ASEAN senior officials meeting on health development and also a ASEAN Health Ministers meeting, which was held in Brunei in 2017. And then this ASEAN Emergency Network for Public Health is led by Ministry of Health Malaysia, as I have mentioned earlier, and it provides a platform among ASEAN member states or officials working at the respective crisis center or disease prevention and control, and mainly is to share the information at timely manner through various communication mechanisms. Rapid and daily communication among the members, such as sharing of information on the new confirmation of cases or any measures taken when the national level is currently done through WhatsApp or mobile application. Daily and regular emails communication is also being done to share updates given by ASEAN member state and +3 countries through the health division, through the ASEAN Secretariat on any new confirmed cases and press releases. This is always been shared in the websites of the ASEAN Secretariat. And also, let me take you all through the key achievements and the milestone of the ASEAN EOC network. It has been working in 2 phases. The first phase started in 2015 to 2017. The first phase was to build the trust among ASEAN member states and initiate sharing of information with some degree of training and work towards the informal surveillance mechanism. Before 2015, we had some training being conducted, but mainly on the ad hoc basis. Then, after that, we had a structured program. Under the phase 2, which started from 2019 to 2022, the aim is to build on the gains that we have achieved in the phase 1 and to establish a structure or procedure to respond. Different areas was led by different AMS. We have areas such as laboratory capacity and networking, mounting a medical and public health response and coordination mechanism, and also on risk assessment and risk communication and building up of the surveillance capability. So, what was the objective when the ASEAN EOC network was developed? So, it is to strengthen the networking between the Public Health Emergency Operations Center of the ASEAN EOC network, and also it is it is to develop an online monitoring system across the 10 ASEAN member states, and also to support ASEAN member states in building their public health emergency operations center capacity and to strengthen our Malaysia's own in-country EOC network. And also it is used to share expertise, lessons, and also experiences in utilizing EOCs for early warning system for coordinating public health emergencies. And also the other objective is to make available a common procedure and protocol to be followed by all the ASEAN member states, and also to develop and implement some kind of training under public health emergency operation centers. And finally, it is also to work towards collaborating with AHA Center in which respect to monitoring disasters, communication, and coordination of public health activity, especially during disasters. So what are the strategies adopted during the ASEAN EOC network? So I'm just going to cover the phase 2, which was 2019 to 2022, and we had mainly 3 strategies. The first strategy was strengthening in-country ASEAN EOC, which is within Malaysia. The second one is to strengthening of the ASEAN EOC network among the member states, and also the third one is collaboration with disaster management in ASEAN region. So under strategy 1, which I mentioned earlier, that is strengthening in-country ASEAN EOC, we had carried out many project activity. The first one is like we are supposed to do some in-country coordination, especially inter-agency emergency operation center network between the National Disaster Management Agency in Malaysia and with various agencies including Ministry of Health. The proposal was developed as early as 2017, but due to various change of leadership under our National Emergency Disaster Management Agency, that was not unable to continue. And also in 2019 to 2022, subsequently, the pandemic was declared, and then currently we are reviewing this policy, and also we are proposing to revive that in 2023 and to be resubmitted. And also we have reviewed the Emergency Operation Center guidelines, and also a lot of SOPs have been developed, especially on all hazards approach, and also mobilization of human resources during public health emergencies also have been developed. So this is done to strengthen our in-country capacity of EOC so that we can conduct the training on for said activities. So under strategy 2, also the strengthening of ASEAN EOC network, we have done quarterly video conference among the Emergency Operations Center in charge, including yearly subscription of Zoom video conference services. Such 16 sharing of information via video conference was conducted since 2019 to 2022, where the speakers are from various ASEAN member states and also including other invited speakers from France, Italy, China, and Japan. And these are the few sharings that we have conducted since 2019 to 2022. You can see the highlighted on the 17 June 2019, which is monkeypox in Singapore. That was first case of monkeypox reported in this region, and Singapore kindly have shared that information with us. Later, if you all know, pandemic was declared in January 2020, and at that time very few limited information was available on COVID-19, and hence then China and Singapore have managed or have shared with us the clinical management of this coronavirus disease. In fact, we ASEAN members got first-hand information from China on what is happening about COVID in their country. And also the other areas that what we have shared is when the vaccination was introduced, we have seen by December 2020 on the western regions, most of the vaccination program have been introduced, but in our region it started early in Singapore in December and also in Indonesia. So we have invited Singapore and Indonesia to share with us how they carry out the vaccination program, especially the mass vaccination program among the targeted group. And then on the 7th September, if you see, Malaysia have led on the mental health issues relating to COVID-19 pandemic. And just the recent activity on information sharing was monkeypox, now which is declared as pandemic. Singapore and Thailand reported a few cases in our region, and they have kindly shared with us the management and also how they did the contact tracing. All this information was very first-hand and very useful under our EOC network. So these are some of the photographs that taken during the video conferencing, as I have narrated previously. And this is also the same sharing of information. As you know, during the pandemic, there was no physical mobility. So what we did was everything was conducted through virtual. And then under the same strategy 2, which is strengthening ASEAN EOC network, we also had some attachment program from ASEAN member state on emergency operations center officers to Malaysia. So they were here from the 1st to 5th December at our Crisis Preparedness and Response Center, or EOC, and 10 AMS participants were involved in this attachment. And these are the few activities that have been carried out during their attachment. You can see they have visited various areas in our emergency operation centers, and also various activities have been carried out and introduced. So same under strategy 2, strengthening of ASEAN EOC network, the third program was a consultation and assistance visits to ASEAN member state, and a visit to Cambodia was conducted previously, and we thought it was very useful to go and assess what is the strength and also the gap which is in the EOC of the country. So it was planned that Myanmar will be the next country for us to visit and assess and offer our assistance in strengthening their EOC. But however, due to COVID-19 pandemic, we were not able to visit. And then the later was the other activity is ASEAN Risk Assessment and Risk Communication Workshop, where we train the ASEAN member state. And also this was already held in 5th to 6th November of 2019. Then later we had a 2 years break. Then the subsequent workshops were just conducted recently in the beginning of this month, which is 2nd to 3rd of November, involving all the ASEAN member states except Singapore. So under the strategy 2 also, we conduct ASEAN Risk Assessment and Risk Communication mini conference was proposed in 2021, but due to COVID we couldn't conduct that, but we have planned to bring this into phase 3, which will start in next year 2023. And also we conducted ASEAN member state training workshop on CBRNE, where it was held in 18 to 19 February 2020, so we couldn't carry it out on 2021, but this subsequent workshop is going on currently today, yesterday and tomorrow in Malaysia. Okay, we will continue with the strategy 2, which is the 7th activity under this strategy is the ASEAN EOC Network Certified EOC course, which conducted in collaboration with the accredited institution. Global Affair Canada has been supporting the entire ASEAN EOC Network training workshop to date. As you know, we have conducted 3 workshops, which is done as an online virtual course. Each course were there 24 participants for each course, and 3 modules were conducted and completed. Then currently now we are going to continue this course into a phase 3, where there are going to be 3 modules, which involve the first online self-learning module, where there will be a big number of participants can participate up to 100, and also then followed by the virtual classroom, where we will have selected number of people will be joining this virtual classroom, and then there will be an on-site training. So this is planned for the phase 3. And then the other activity is also in Cambodia. They have already, we have joined to develop a generic SOP for all multi-hazard public health emergency response approach for ASEAN member state, which was done in July-August 2019, and also conducted laboratory training on flavivirus surveillance in 2019, and also ASEAN member state in-country surveillance on procurement of flavivirus test kit also was conducted in April 2022 with ASEAN member state participation. And also the other activity under strategy 3, So this is the first activity that we have conducted under Strategy 3, which is ASEAN EOC Network Collaboration with Disaster Management in ASEAN, which is a consultative meeting between the ASEAN health sector, that ASEAN senior officials meeting on health development, with disaster management, which is the ASEAN Committee on Disaster Management. So there were integration of Public Health Emergency Center in standard operating procedure for coordination of medical emergency medical team in ASEAN. So this activity is ongoing. And these are the other activities that conducted under Emergency Operations Center. We had a visit from the Korean CDC and Emerging Infectious Disease Response Team visiting our EOC to look into our structure and also look into our functions. And then just recently we had a visit from Thailand, Cambodia, and also Laos to Malaysia as a consultative meeting for emergency preparedness and response because they wanted to test the developed international coordination mechanism guideline, because how do we coordinate with the border countries, especially on information sharing. So we had a very detailed discussion on this, and also we have come out with this international coordination mechanism or a guideline, where we will be, it is still in the draft stage, however, we will be finalizing it soon. So there were activities also carried out during their visit, where they have visited our state emergency operations center, followed by the district emergency operations center, and also they have visited health clinic, where actually the input of various events will be get notified from. So with that, I will just like to summarize the success story that we had under our ASEAN EOC network. And we feel that it's a very good coordination platform for all the ASEAN members in sharing information. As I've already briefed earlier, 16 virtual video conferences were conducted with the timely sharing of information on the event that is occurring in our region. And also, this ASEAN EOC network support the ASEAN member state in building their public health emergency operations center capacity through workshop and training. So we conduct regular risk assessment and risk communication training, CBRNE training, and also EOC attachment. And also developing the guideline for EOC, CBRNE, all hazard, and also on mobilization. Then the other main activity was our response during COVID-19, which we had early rapid information sharing exchange, especially even we have a WhatsApp group among our member states where we share and clarify a few events directly with our focal point at various ASEAN member states, and also not only from our member state, even from outside ASEAN region like Italy, France, China, and Japan, who have willingly shared their experiences in managing COVID-19. So, however, while conducting this, we still face few challenges, which I think we are trying to overcome over time. So, one will be we need to tailor the need of different ASEAN member states with different capacity, because we know that the capacity differ between the ASEAN member states. So, when we do a training, we have to tailor to meet all their requirements. That is really a great challenge for us. And also language barrier, because we speak multiple different languages at different member states. So when we all come together, we have to have a common language and understanding. So that is also a challenge. And the third one is lack of expertise in required specialized area of training. Sometimes we need some specialized training where the lack of expertise was there. Like, for example, I can say like external quality assessment for laboratory, where we still find there is not much expertise in our region, and also bioinformatic on lab. So that also need to be specialized. So we are still depending on partners to help us to build up this capacity. And also finally, the commitment from the ASEAN member state, because we have various activities which will be going on at the same time. So participation and also contribution sometimes is very challenging from the member state to be everywhere all the time. So these are the few challenges that we are facing, but I think over time we will overcome all these challenges by collaborating and cooperating with our ASEAN member state. So I think this is the only presentation from me today. I would like to thank you for all your attention. Thank you very much.
네, 고맙습니다. 이렇게 해서
Thank you. It was Dr. Tilaka from Malaysia. Now we are going to start our third session. The last session of the day is about our measures to reinforce international cooperation to respond to infectious diseases. In the third session, we're going to have a panel discussion, so I'd like to encourage all of you to stay with us until the very end of the discussion.
Professor Kwak Jae-sung from Kyung University will talk about how to undertake effective capacity building program for response to infectious diseases under ASEAN-ROK partnership framework. 안녕하십니까? 발표 자료가 나왔나요? 우리가 좀 원래 일정보다 좀 뒤쳐져 있죠.
Discussions to have after my presentation, so I'll try to shorten my presentation as much as I can, probably in 6 to 7 minutes. The topic I brought you today is how to undertake capacity building program for effective response to infectious disease under ASEAN-ROK partnership framework. Basically, we work with ASEAN and ASEAN Secretariat and member countries over the response to infectious disease, and we focus on capacity building program. Myself and my team, in partnership with the Suncheon University Medical Center, we have done some work for last 3 months to design a midterm means 4 to 5 years, capacity building program on this topic in consultation with other partners and stakeholders. Basically, my presentation can be summarized in 3 sentences. We've done some work, many works for demand identification, as you see here, or literature review, survey, and focus group interview, and we've done some field studies to many countries. And then we identified some existing programs. The purpose is to get some niche and some demands that only the Korea can offer to avoid the possible duplication as well. So there are existing programs and initiatives and networks as we have learned from other partner countries. However, still, we have learned there are some demands. So second thing we've done is we have identified some needs here in terms of policy, emergency management, and laboratory. Something like there was huge demand on the risk communication system and also establishment of a laboratory management guideline and biosafety management and samples transportation. Even we discussed some possibilities about using drones with fuel cell, which is future item, and apparently some data management for epidemiology especially. So here are some demands. And we have set some principles for developing capacity building program. It should be demand oriented and competency enhancement as a key, and we emphasize on practicalities, mixing the theories and actual site visit, and probably the short-term internship could be introduced here. And 4, we have to avoid the duplication. Number 5, it should be sustainable, it should be scalable. We not only train or share our knowledge with existing participants, we want function. You want to use the trainees and participants as a platform for their own respective countries. And peer learning, extremely important. Any country, whether the level of development for infectious control is high or low, there are something to learn each other. So in the course of our communication, and many countries have offered, our experience was low cost, highly efficient, and it worked. Then that's the thing that we can learn each other. That's the art of South-South cooperation, I think. And finally, international cooperation is needed, not only with existing ASEAN networks, also we'd like to also work with many other donors. Some have mentioned that US CDC and Canadian agencies are also deeply involved in our efforts. So we'd like to also coordinate with other partners as well. So these are the ground principles that we have developed the program. And then number 3 sentence, we've done some menu. We have prepared some menu for you here. So first, how are we going to do? So we're going to mix the online and invitation training as we've done in the year 2022. As for the online training, there will be shared the Korean experience and cross-cutting lectures, and also some topics of generic skills and knowledge, like statistics or number crunching, which will be pretty useful. For the invitation training, we still stick to the 3 pillars that we have agreed with the ASEAN Secretariat: emergency management, laboratory response, and epidemiology. And year by year, we will have new themes over the corresponding to each training program. So this is kind of quasi completed menu here. Online module will be Korea's experience and cross-cutting issues and action plans. Offline invitation training with yearly themes. These are the possible themes that we can introduce in terms of emergency management, emergency response guideline for risk management, and systems digitization and data science, and regional response to infectious disease. For instance, integrated surveillance information system is now being introduced in many countries. So we'd like to adopt some of these menus, something like this. I took it from our Bangkok friends, and they've been doing this processing in their EOC with regard to the surveillance information system. And what about laboratory system? So quality assurance is extremely important these days. So what about facilitating the other member countries to get the certificate or something like ISO? Finally, in terms of epidemiology, so we can introduce some human resource management or respond to zoonosis, One Health, which is an emerging important issue here. Well, this is an example that we need some knowledge and skills on stockpiling. This is literally the stockpiling, but we are not talking about this. We are talking about the whole value chain of stockpiling. When you get those stuff and supplies for the infectious disease response, then how are we going to manage all those stocks and how are we going to distribute? What about using some digital devices and applications for the efficient, effective management? Actually, in Korea, we do have some of those newly developed stockpiling system because our partners were not able to actually participate in this program visit yet this year. However, in the forthcoming years, we will try to arrange a visit here. Okay, I think finally, ASEAN-ROK partnership strategy still is the comprehensive regional approach and strengthening partnership. I'd like to echo one more time. We have partnership with ASEAN and member countries. At the same time, we will strengthen the extra-regional partnership through coordinated and harmonized common efforts. So our research will be ongoing. At the same time, we will solidify the training programs for forthcoming years. That's all I have today. I used 7 minutes. Thank you very much.
네, 고맙습니다.
Thank you very much, Professor Kwak, so that we could catch up some of the time. And it's the next the presentation. So regarding the lab, Professor Lee Hyung-min will give a lecture. Please welcome him with a big round of applause. Thank you very much for introduction. 제가 오늘
저도 조금 내용이 많아서
Today I would like to talk about the diagnostic strategy and laboratory capacity for early response. To save the time, I would like to speak in Korean. So, about my background, the COVID-19, the diagnostic tests were dealt by the 90% by a diagnostic system, and I was in charge of that. And the Korean Medicine Society, I was chaired for that. So about the COVID-19, this is the current status. Around the world, several the surge were happening, and now it's coming down. And the Omicron is already seeing another surge, and then we are seeing the seventh surge. So the Korea and the whole world's trend is a little bit different. Korea, around the world, 6.6 billion people died, but in Korea, 26 million was infected, and the mortality rate is about 0.1%, which is very lower than other countries.
I believe there are many reasons behind this. So the benchmark is the number of people who died of COVID-19 per 1 million people. But Peru has the largest number of people who died of COVID-19 per 1 million population. In the case of the US, the number is more than 3,000. However, in the case of Korea, it is only 500 or 600. So compared to the mortality rate, Korea is in a relatively better situation regarding the response toward COVID-19. So we need to take a look at why this happened, why Korea had a good performance regarding the response to COVID-19. If you take a look at this curve, most of the COVID-19, most of the deaths happened in the initial stage, and then the trend has mitigated in the after the first phase. So almost 90% of the deaths happened during the first phase of the pandemic. So in the case of the US as well, the same pattern applies. From February to March last year, almost 1 million people died of COVID-19. So the number of deaths increased on a steady manner, but at some point, the trend starts to be mitigated. I think Korea has a little bit different pattern than other countries. As you could see, before the pandemic of the outbreak of Omicron, we only had around 3,000 deaths. So we were able to suppress the spread of COVID-19 before Omicron. However, after Omicron, the number of deaths increased significantly. But these patterns are closely related to the number of deaths because whenever we respond to EID, the initial stage, the number of deaths is destined to be high because we don't have any immunity toward the new disease. So most of the victims in the earlier stage have no immunization against this newly emerged disease. And this EID does not affect only those with the existing risk factors, but also other people without such risk factors. So the number of deaths per 1 million population was high in the US compared to Korea. If you take a look at this table, we categorized the number of deaths by age group. So we have different numbers of deaths per age group. So the absolute number of deaths is 7 times larger in the US than that in Korea. However, if you take a look at the table in a closer manner, you can see that the deaths were not specific to certain age group. So especially for the elderly who are aged over 80, the number of deaths was 6 times larger in the US than Korea. But more surprisingly, if you take a look at the 40s, those between the age of 40 to 49, the number of deaths was only 49 in Korea. But the number was more than 1,700 in the US. So the number or the scale of damage is not just 7 times. Of course, it is severe. However, we need to think about that COVID-19 did not just affect the elderly people, but this economically activated age group as well. What's most important in order to minimize our damage is that early containment. We need to make sure that we minimize the initial damage from newly emerging disease. That is why Korea adopted strong countermeasures in the early stage of COVID-19. And these measures should be continued until majority of our population get immunization. In order to get immunization, we should get vaccinated or we should be infected first. I think in the case of Peru, the pattern or trend of infection started to be mitigated in the later stage, but I think it is because of infections, not by vaccination. Anyways, whether it is from vaccination or previous infection, the highly vulnerable group has to be protected by adopting strong measures in the earlier stage. That is why I stress the importance of early containment. But we could see one characteristic from Korea's trend. Unlike other nations, in Korea, we experienced a local communities outbreak in Daegu. So from Daegu at that time, we experienced a sudden surge of the number of confirmed cases. But if you take a look at the trend of other nations, you could find that other nations did not have that many confirmed cases. But is it real? Do you really think that other nations did not have that many confirmed cases at that time? Quarantine measures does not guarantee the prevention of any disease. So some patients are in its latent period, and some patients has less symptoms thanks to medication. So only half of total patients were confirmed. Then other half were not confirmed, and these not confirmed cases will be moving around in our local community, and it will make further infection in our neighborhood. So I doubt that in this period, other nations did not have this many confirmed cases like Korea. because all of a sudden the US has more than 3,000 confirmed cases at some point. So I think it is because other nations at this time did not test much population enough. So we need to have proper level of testing capability in the earlier stage. So COVID-19 and other types of EID could be spread faster than our imagination. So we need to make sure not only confirmed cases, but suspected cases should be tested on a timely manner and treated fast. So in order for that, we established laboratory diagnostic system. First of all, lab diagnostic strategy should be explained first. We do not have universal diagnostic system for every type of disease because each disease has specific characteristic. So this diagnostic system has to consider many aspects of a certain disease. But we need to be based on risk assessment whenever we develop diagnostic strategy. And within the strategy, we need to pinpoint what kind of testing method and what kind of samples would be applied. And also, we should define who should be tested and what kind of diagnostic testing capacity is needed and who should test the patients, etc. So based on these capabilities, Korea tried to establish this kind of diagnostic strategy. So there are three types of testing for COVID-19. First of all, we have a molecular diagnosis. But it takes a couple of days to get the confirmation. And this methodology has a high sensitivity. That is why the Korean government selected the molecular method. So once we have high molecular test capacity, we could effectively deal with COVID-19 and this type of newly emerging disease. I believe you've seen this graph. With limited human resources, thanks to this molecular diagnostics methodology, we were able to test confirmed cases on an earlier manner. But here I'd like to share two ideas. First, it's easy to increase the number of testing. However, it's not easy to increase our testing capability. How do we know one country can... we need to have a good laboratory system in order to make sure how many cases this country can test per day. So we need to control the capability of one nation as a whole when it comes to testing capability. And in the case of Korea, the maximum testing number was 900,000. But do you think 9,000 testing could be covered by a couple of laboratories? No. So for this EID, we need to put the maximum level of testing capability of a country. So we need to analyze the overall capability of a nation when it comes to testing. And second, we should define who should be tested. So we believe that only suspected cases should be tested. However, we need to test epidemiologically connected people as well. In the case of COVID-19, and this kind of EID could be spread unknowingly in our local community. So we need to find these hidden cases within our local community. That is why we need to have unknown cases to be tested. In order to do so, we need to have high-quality test capability and also surveillance system to detect unknown cause and unknown cases. With the spread of COVID-19, we need to have a variety of testing methodology. That is why we need a diagnostic testing system. So in each stage, we need to make sure if we have immunization, and also the method of testing should be evolved according to this phase of a pandemic. And also, I'd like to briefly talk about laboratory diagnostic strategy. Then how we could establish laboratory diagnostic system for every disease. In order to do so, we first need to address problems. So according to Euro survey, these are the problems that we need to address first. We could take advantage of the existing accreditation system, and also we can take reference to the existing system. So within a short period of time, Korea was able to pan-governmental diagnostic system. I think this does not apply to every country because we have different situations. That is why we need to establish expertise first and also laboratory system first. To do so, we need to establish overarching network within our medical society, and also we need to nurture medical service providers. So the number of laboratories matters, of course. However, we need to establish a system where this laboratory capability could be upgraded in the times of crisis. And also, for the sake of laboratory network, we need to make sure these activities are made. So in the short term, diagnostic capacity affects our quarantine policy, but in the long term, we need to make sure our diagnostic capability is upgraded and maximized. So in conclusion, as I mentioned earlier, EIDs could be spread earlier and faster than our imagination in our local community. That is why we need to have earlier or proactive measures. And also, these measures should be applied nationwide. And in order to upgrade these measures, we need to have testing methodologies and experts. This concludes my presentation. Thank you for your attention. Thank you, Professor Lee Hung-min, for your presentation. So we are talking about diagnostic strategy from each segmentation. So first session was a laboratory.
Then let us invite the Professor Kwon Dong-hyuk, Division of the Public Health Emergency and Response Research for the Korea Disease Control and Prevention Agency.
See you all in person. Last time we met online in October. Okay. Contents are as follows. And first, I'd like to introduce National Infectious Disease Surveillance System in Korea. According to the infectious disease prevention law in Korea, national notifiable infectious diseases are composed of 4 categories, from group 1 to group 4 diseases. In this table, you can understand the description of group 1 to group 4 diseases. In specific, group 1 to group 3 infectious diseases are under mandatory surveillance, and group 4 diseases are monitored through sentinel surveillance. As a supportive surveillance, there are Korea National Healthcare Associated Infection Surveillance and ophthalmology surveillance. In addition, KDCA plans to establish a wastewater-based surveillance, and I will present more in detail later part of my presentation. This shows a cascade of reporting of infectious disease in Korea. Medical doctors, oriental medical doctors, or dentists who diagnose group 1 to 3 infectious disease have to notify to the head of the medical institutions. Then the head of medical institution has to report to public health center in city or county level, then to Department of Health of provinces. The governor of a province have to report to KDCA. Each institutions report cases through the Integrated Infectious Disease Management Information System. This shows an example of electronic report form. Collected data has been disseminated in various ways, such as through KDCA internet portals, public health weekly reports, infectious disease surveillance yearbooks, and through weekly sentinel surveillance reports. Now I'd like to introduce several best practices of sentinel surveillance in Korea. Influenza-like illness IRI surveillance is composed of around 20 clinics of internal medicine, pediatrics, and family medicine. Each clinic reports cases with IRI symptoms such as fever over 38 degrees and cough or sore throat on a weekly basis. IRI index can be calculated, and if the index value is higher than the criteria, then the warning of influenza epidemic is declared. IRI index for 2022 to 2023 season is 4.9, and on week 37, the warning of influenza epidemic was declared, and influenza epidemic is ongoing currently. Korea Influenza and Respiratory Virus Surveillance System, in short, KINRES, is a laboratory-based surveillance. 77 among 200 clinics which take part in IRI surveillance participate in the lab surveillance. 8 respiratory viruses causing acute respiratory infection have been monitored, which include influenza, adenovirus, parainfluenza, and other respiratory viruses. On the severe acute respiratory infections surveillance, 42 tertiary hospitals or university hospitals have participated. Each institution reports the number of hospitalized patients with acute respiratory illness within 10 days of admission. The outcomes are the proportion of the SARI patients to total admitted patients and the rate of ICU admission and fatal cases. These sentinel surveillance results have been published online through weekly sentinel surveillance reports. From now on, I'd like to talk about wastewater-based surveillance as a supportive surveillance. Any given compound consumed will subsequently be secreted. Endogenous and exogenous human biomarkers can be identified and quantified in wastewater, and this can provide a reflection of the population's health status in real time. The United States have established and operated national wastewater surveillance system since 2021. Sewage samples have been collected from more than 1,000 wastewater treatment plants and have been analyzed for COVID-19 RNAs. Each state in the US has created its own dashboard for sharing wastewater surveillance result. SARS-CoV-2 RNA concentration obtained from wastewater has correlation with reported new cases in a county in New York State. Monkeypox virus also has been detected in wastewater, and many states monitor monkeypox regularly through National Wastewater Surveillance System in the USA. In the UK, a nationwide wastewater monitoring program has been implemented for the early detection of SARS-CoV-2 variants and to monitor the trend of the concentration of SARS-CoV-2 RNA in wastewater. Recently, traces of vaccine-derived poliovirus type 2 has been found in London sewage, and the UK Health Security Agency recommended injecting polio vaccine targeting children under age 5 who live in London and have not been vaccinated for poliovirus. From now on, let me introduce a pilot project of wastewater surveillance in Korea. Wastewater treatment plants in Seoul and Daegu City were monitored for SARS-CoV-2 RNA concentration. As a result, a similar trend was observed between SARS-CoV-2 RNA concentration and COVID-19 cases in the wastewater treatment plant served area in Seoul. And the RNA concentration increased rapidly 14 days ahead of the explosion of COVID-19 cases. Through the second pilot project in Sejong City, which is located in the middle of Korea, we tried to monitor various kinds of pathogens, including SARS-CoV-2, water and food-borne pathogens, and respiratory viruses. Wastewater treatment plants, educational institutions, public facilities, and hospitals have been monitored. This shows sampling of the wastewater at various sites. Manholes at Sejong City Hall and Nursing Hospital, a wastewater treatment plant, and manholes at a university dormitory. In total, 66 samples were collected from diverse sites and tested for 32 pathogens. And we could detect 12 pathogens, including SARS-CoV-2, from the wastewater. In addition, we could find correlation between RNA concentration in wastewater collected from a university dormitory and reported COVID-19 cases in Sejong City. As a public health response, we are conducting screening of COVID-19 targeting high-risk facilities for early detection of patients and preventing them from becoming severe and fatal. Sewage samples from selected nursing homes, nursing hospitals, and mental hospitals were collected and tested for SARS-CoV-2. If RNA were detected from sewage, all people in the facilities will be tested for COVID-19, and confirmed cases will be quarantined for the prevention of further spread of virus at the facilities. Through the pilot project, we could detect RNAs of diverse pathogens and could understand correlation between RNA concentration in sewage and confirmed cases in the region. After all, we are planning to establish wastewater surveillance system in all provinces in Korea. Provinces will designate at least 2 wastewater treatment plants for sampling and will screen SARS-CoV-2 norovirus and 8 acute respiratory viruses every week. KDCA will collect data from provinces and will publish weekly nationwide wastewater surveillance report. In summary, I introduced a national infectious disease surveillance system in Korea, mandatory surveillance, sentinel surveillance, and especially wastewater-based surveillance as a supportive surveillance. To cope with a new public health threat, we need to consider new type of surveillance which can support existing infrastructure. KDCA will establish wastewater-based surveillance as a new method. I'd like to cooperate with you on improving surveillance system in Korea and in your countries. Thank you very much for your attention.
네, 고맙습니다. 권동혁.
Thank you. It was Mr. Kwon Dong-hyuk, Director for Public Health Emergency Response Research from KDCA. Now we have our last presenter. This presenter is talking about epidemiological investigation. Mr. Park Yong-jun, Director for Epidemiological Investigation Analysis at KDCA. Please welcome him with a big hand. Hello, everyone. I am Director for Epidemiological Investigation Analysis, Park Yong-jun. Sorry about me speaking in Korean in this international conference. Today, I'm going to talk about the importance of international collaboration in infectious diseases epidemiological investigation. So this is a very familiar image for all of you, I think. I first saw this image back in 2015. Compared to the year of 2015, now we have a faster interchange of people and culture, and now the population reached 8 billion globally. And this image was captured from WHO website in order to explain the importance of our preparedness for pandemic influenza. We do not predict where, when, and what types of influenza virus will appear, and how the influenza virus will be developed into pandemic. That's why they say it is predictably unpredictable. While we do not predict where, when, and what kind of virus will appear and how it will cause a pandemic, despite technological development, however, we can predict that compared to the past, the frequency of disease X will be shortened, and if the disease X appears, the speed of spread will be accelerated with bigger impact in public health, society, and in our economy. That is why we need to make a preparation. I believe we have made many developments based on the past lessons and past experiences. So in the earlier stage of COVID pandemic, thanks to our experience, we were able to make effective initial countermeasures. And it is pretty successful in the past 3 years. We were able to share the patient information, diagnostic information, and genome information on a faster speed, unimaginably fast in the past. And also these information were utilized in order to design proper strategy and policy. And for vaccines too, as you know, on a faster manner, we were able to develop relevant vaccination. And globally, the vaccine saved a lot of lives around the world. In my opinion, epidemiological investigation also made development, especially in order to share the relevant information faster and more accurately. Epidemiological investigation made great contribution. And also, when we share this information, channel matters. What channel we should use is important.
또는 기존에 있는
In the wake of the COVID-19, we utilized the existing platform or we developed new channels. This diagram is how we shows how we share our information on a global manner. Vaccination and the number of deaths and prevalence of COVID-19 are shared on a real-time basis between countries. And thanks to this information sharing, public health authorities around the world gained a lot of benefit. And thanks to these platforms, we were able to get many benefits as well. In this slide, you will see a number of sites where we could share the result of recent research projects. And also through Outbreak Info, which is a new platform, we could check many academic papers about the pandemic. Thanks to this evolvement or development, we were able to transition the existing pandemic influenza preparedness plan or Disease X preparedness plan to new plans relevant to this pandemic by swiftly scaling it up. Also, our experience in the pandemic will be a standard model for future potential pandemics. And our know-how and approaches toward COVID-19 will be utilized to the unknown diseases happened in 2022. And also for monkeypox, we were able to share the epidemiological data through these Outbreak Info and other new platforms. Epidemiological investigation planning and report, format of the report, and how we disclose the information. All these have also developed further in the wake of the COVID-19. I think the result and report could be collected on a more real-time basis and or on a more timely manner, and it is being shared with the global society. So the slide summarizes the initial epidemiological investigation about monkeypox, and this was conducted in England. And this one is also an epidemiological investigation about monkeypox conducted in the US. So like these, we were able to share epidemiological data in an earlier stage regarding monkeypox. And thanks to these earlier information sharing, we were able to deal with the monkeypox situation better. And I'd like to share Korea's cases as well. Korea has applied multiple approaches regarding epidemiological investigation for our response to COVID-19. Mainly, we wanted to share the results through academic papers or academic journals so that many public health institutions around the world can take advantage of the data so that they can adjust these data relevant to their situation. So if you take a look at the right side, it summarizes the result of our initial risk assessment. And mainly, we reported the pattern of group outbreak cases, and also we wanted to detect the pattern of outbreak in Korea. And also, we wanted to make sure if the COVID-19 could be spread on airborne basis. And we also continuously monitor the change of the pattern of epidemiological investigation in the wake of COVID-19. So we wanted to make sure the latent period and what kind of change has made in the period, the latent period after vaccination. And also, we put focus on the effect of vaccination. So since March last year, on a periodical basis, we conducted a survey on the impact of vaccination. And based on these reports, follow-up actions were implemented. To summarize, so in order to make effective actions in the field of epidemiological investigation, we wanted to have transparent information sharing. So by sharing and by comparison, we could understand better. So based on this better understanding, we can make better preparation and better response to this crisis. At the same time, I'd like to recommend that we should take advantage of the existing system and existing infrastructure. And I'm confident that the Pandemic Influenza Preparedness Plan, which celebrates its 10th anniversary this year, made great contribution to our response toward COVID-19. So based on this existing plan, we could make adjustment and update. I think this is more practical way to make timely response to the pandemic. For your information, I brought this slide. You can take reference to this slide when you make your own plan in your country. Personally, I'd like to emphasize these 4 areas: surveillance, investigation, risk assessment, and intervention. So we need to distinguish these 4 areas, but at the same time, we need to link these 4 areas. But sometimes we need to expand our preparedness by making adjustments according to our local situation. This concludes my presentation. Thank you. Thank you for your presentation. The last presentation was about epidemiological investigation, and at the same time, he mentioned the importance of cooperation on a global stage. So now we are going to have panel discussion. We are rearranging the podium and the floor. So for the stronger international cooperation to respond to infectious disease in the region, we are going to have a panel discussion. So in the previous presentations, Professor Kwak Jae-sung mentioned about the importance of international cooperation especially between Korea and ASEAN, and also Mr. Kwon Dong-hyuk talked about the importance of the establishment information analysis and surveillance system. And lastly, Mr. Park Young-jun talked about the epidemiological investigation and the importance of international cooperation in the field of epidemiological investigation. Thanks to this information sharing and experience sharing, I believe we're going to have more meaningful discussion. With regard to this, our response to pandemic, we had an opportunity to listen to the opinions of our experts. Now we're going to have panel discussion. So I'd like to encourage you to stay with us until the very end of the panel discussion so that we could have more meaningful discussion with all of you. So under the theme of international cooperation for better response to the pandemic in the region, we'd like to have a panel discussion. The panel discussion will be moderated by Mr. Lee Hoon-sang, the CSO of RIDE Foundation. And also we have a great panelist for high quality discussion. Please wait for a couple of seconds until we rearrange our floor. I believe the rearrangement is almost complete, so let me introduce our moderator for the panel discussion, Mr. Lee Hoon-sang, CSO of RIDE Foundation. And the moderator will introduce our panelist by himself.
Now, the panelists are on the stage, so let me hand my mic over to the moderator. Hello, my name is Lee Hoon-sang from the Foundation. Thank you very much for all those meaningful presentations. We are behind the schedule. We have only a few minutes left, regrettably. So we wanted to hear all those comments from the panelists, and we were going to get into the Q&A session, but we don't have enough time for that. So I think we have to skip to the Q&A session directly. And so panelists can answer the questions from the audience while mentioning your opinions on this part of presentations. Today we have invited 4 panelists, and among them, the 2 gave the presentations, the Professor Lee Hyung-min and also the Mr. Ferdinand, and Fernando, you gave these presentations already. And we have 2 more panelists. The Director for International Affairs of KDCA, Yoo-jin Jung, is present. And another panelist is Professor at Hanyang University College of Medicine, Sung-hae Kim.
네, 그러면은 바로 패널.
Then let's dive into the Q&A session directly. So we can recall what was presented, and also we can discuss the future collaboration trajectory. So let's start the panelists with who did not give presentation. So I think it would be you who listened to all those presentations like you're studying, Ms. Yoo-jin Jung, because you are the director for the KDCA. So it might be a difficult question, but as for the KDCA in Korea, and in terms of cooperation with the Asian countries, what would be your priority? Also, you're seeking for the cooperation with ASEAN member states and the WHO's WIPROs, and so you're conducting a lot of international cooperation projects with a lot of parties around the world. And also, you have to get the most out of this the cooperation project with ASEAN member states, but there are other like Japan, Australia, and so there are stakeholders in those countries who are seeking for cooperation with ASEAN member states as well. But then, from the Korean government's point of view, what would be your the priority to seek for the international cooperation with ASEAN member states? Okay, so let me answer your question. Today, we could also hear a lot of ideas and presentations. Taking this opportunity, how can we get ready for the COVID-19 or the infectious diseases? So we are talking about a lot of preparedness and the countermeasures for COVID-19, and many are developing the pandemic accord, pandemic defend. This kind of massive scale of the countermeasures are discussed. The KDCA is also taking part in those initiatives. As many presenters already mentioned before, one thing we have to take more consider is that we need the solidarity among experts, and we have to cooperate together, and we have to study from each other. I think that's one thing that is very important. So the KDCA is a dedicated agency to prevent and manage all those infectious diseases. So we have to expand our roles and responsibilities. And this is also the purpose of the international cooperation with ASEAN member states. And the capacity building program is as part of that initiative. Taking this opportunity and non-contact or the invitational training programs and this kind of conferences, we can share technologies and information and experiences with each other. And also we can discover what kind of rooms we have, and then we can also decide which can be a good focus that our international cooperation project can work on. So far, there were a lot of international cooperation projects which have been done. But while going through the pandemic, we could learn that, okay, there were some missed spots that we have to fill. And a lot of countries were feeling that aspect, that there are more the rooms that we have to cooperate. The infectious disease preparedness and response related experts and policymakers, we all should be connected to each other. So that's one thing we are working on at this moment. And also you mentioned the WHO WIPRO and Korean government's relationship with that organization. With that one, the approach is almost similar, but WIPRO is working for the Western Pacific countries, and we are providing the guidelines to provide the public health related the measures. But through the WHO WIPRO, the voluntary fund is given, and we are making more opportunities to seek for bilateral cooperation with countries in the Western Pacific countries. With injection of this fund, we can give more other chances to cooperate and work together. The future cooperation can be done along with the global scale of cooperation. We have to strengthen and fill up the missed parts of the initiative. So the practical initiatives are needed. To that end, KDCA will do its utmost. Thank you very much.
So KDCA has made a cooperation with ASEAN members, and I think going forward, KDCA will expand their cooperation. So Korea's experience and capability should be shared, and in order to do so, KDCA will provide a channel or a corridor, and also together with many stakeholders in the West Pacific region. I think she mentioned that Korea will play a role as a linchpin in the region. Now, I'd like to ask questions to Dr. Fernando. So, although I'm asking questions in Korean, you could speak in English, of course. So, my question is,
Speak English to you for the questions for Ferdinando. Continuing from the previous discussions, in ASEAN Pacific region and Southeast Asian region, there are various governance structures such as ASEAN and WHO, Western Pacific regions, and CRO regions. And various funding or partnering countries such as Canada, Australia, Japan, and United States. So there are many of the different mechanisms for governance, and there are various different initiatives such as APSED-3, and ASEAN has its own ARICRID, and ASEAN Public Health Emergency Coordination System and such. So in this current situation, how would you recommend Korea to work with ASEAN and also make the contributions toward the strengthening of the pandemic response governance mechanism in ASEAN region? And what would be your recommendations?
Thank you so much. I am the non-Korean in this panel. I think for the next 2 or 3 years, I think I should learn Korean as well, so that better communications could be manifested in the future undertakings and communication exchanges. With regard to the question, number one consideration in terms of enhancing external cooperation with dialogue partners, development partners. So what do I mean by this? Cooperation with external governments that have strategic partnerships with ASEAN, and also cooperation with institutions as well as other agencies like the UN agencies, including the WHO. Now, in terms of enhancing cooperation, number one consideration would be ASEAN centrality. This is in the context of the ASEAN architecture. There is an ASEAN mandate, there is an ASEAN architecture, meaning ASEAN governance and implementation mechanism that would involve various stakeholders that are interested in the political security domain, economic domain, and socio-cultural domain. However, there are cross-cutting issues that needs to be discussed. Regardless of the type of cooperation with any partner, regardless of the type of contribution, collaboration, and coordination, what is essential in terms of ASEAN cooperation with other partners is, as I've mentioned, ASEAN centrality. It should be within the framework, within the mandate, within the priorities of ASEAN. Case in point would be in terms of the ASEAN health sector cooperation. What would be our mandate? Our mandate is based on what has been pushed or advocated and tasked by the ASEAN health ministers, our highest level of governance within the ASEAN health sector cooperation. Based on the directions of the ASEAN health ministers, the working document or the working mandate that would be the point of cooperation or entry points of cooperation would be the ASEAN post-2015 Health Development Agenda, as well as its 21 health priorities focusing on promoting healthy lifestyle, responding to all hazards and emerging threats, enhancing health systems, strengthening health systems and access to care, and ensuring food safety. Now, these are the points of, or entry points of cooperation. However, there is also the programmatic aspect. We have discussed the policy, the mandate. Now, in terms of programmatic or operational cooperation, all of the stakeholders, including our partners from Korea, should also work within the governance and implementation mechanism of the ASEAN health sector. Also, in the bottom line, aside from ASEAN centrality and aside from this governance implementation mechanism already existing, there should also be concurrence among ASEAN member states. There should be consensus among the ASEAN member states in terms of what would be the priority areas of cooperation at the regional level. The focus of the ASEAN health sector cooperation is regional level, which would address common gaps, common needs among ASEAN member states. The regional direction should also be localized. That's the third point. Localized in terms of how it would contribute to the national priorities, in terms of their programs, and in terms of their important activities that would focus on national and subnational and local community undertakings. In addition to this, there should also be a, you might say, no conflict of interest in terms of engagement with any other stakeholder. That's the reason why we also have this rules of procedure for the engagement of entities with the ASEAN health sector in terms of ensuring that all of the motivations, intentions, as well as the end results of cooperation would lead to the goals of ASEAN health sector in terms of ensuring a healthy, sustainable ASEAN community. Thank you.
Thank you very much. So I guess ASEAN governance
감사합니다.
structure, but since it is kind of a political body, it can bring in its own leverage of the political commitment as well beyond the sectoral commitment. So I guess regional level commitment can be generated through this ASEAN structure. I think this can be one of the key benefit of working with ASEAN, I guess. But I guess there are many of the ways that we can work together, it seems. So I will go on to the next questions because due to the time. 김성혜 교수님께
Then let me ask the Professor Kim Sung-hee. So maybe I might ask some of those the fundamental questions to you. Among the presentations, we learned about the achievements in response to COVID-19 by the Korean government, QQIT, TTIQ, or isolation, quarantine, behavioral change, and social distancing, and the preparedness and swift initiative and responses, and universal the national insurance health insurance coverage. All those items were covered so by Director Chung and many professors. So all these good aspects were emphasized, but ASEAN nations are heterogeneous, and each nation has different context. So among many success factors, which can be the main point to share our experiences with the ASEAN member the states? Because you worked in this international cooperation for quite a long time and you understand the whole context, and also you understand the each nation's culture. So that's my question goes to you. Thank you very much. So the Korean government's response system were covered a lot by various presentations, but the package is has many layers, and so there is no magic bullet, or there is no a total package to cover the whole needs of this whole countries. So I think the total package is not the convenient or beneficial to all those the stakeholders. So among all those measures, which are beneficial? I think we need to ask each member state because they have different needs and different situation. Now, the KDCA, along with KOHAI, is organizing and hosting this event.
And this part is this conference is as part of that effort. So using the ASEAN network and also reflecting each nation's this status and condition, maybe we can use this difference as kind of a platform. So it need assessment and situational study. So all these studies should be well done. So I think you can work with the ASEAN Secretariat so that all these surveys can done in depth. And I looked up some of those the cooperation project working with ASEAN member states, and biodiaspora was one of them, along with the Canada. Big data was accumulated. Virtual AI platform, real-time decision making. So that was one of those the cooperation project. Since Korea has the top-notch the ICT technology and we have experience in dealing with COVID-19, so maybe we can make a new the measure to help the ASEAN member states. So resource aspect was covered, and thank you very much for your comprehensive answer. So there might be some the member states which have very similar the context with Korea, and then also there are many developing countries, and there are countries who have different needs. So we can seek what kind of support should be provided to the country, and like biodiaspora, by benchmarking or utilizing that, we can add some more elements to provide a better solution.
Lastly, I'd like to ask a question to Professor Lee Hyung-min. Professor Lee talked about the importance of laboratory. So regarding laboratory, especially about laboratory strategy, Korea designed a good laboratory strategy, and we have a regional level laboratory. And for these regional laboratories, we should make quality assurance. I think Korea did pretty good job regarding this quality assurance for regional laboratories. And the reason why Korea was good at this regional laboratory is because we were able to provide high quality assurance technology, and also academia, the private sector, as well as the public sector made collaboration immediately after the appearance of the pandemic. So the cooperation between the academia, the public sector, and private sector matters very much. And this experience should be applied to ASEAN countries too. Of course, this does not have any specific answer, but I'd like to ask for your kind of recommendation for potential approach to apply Korea's laboratory version to ASEAN countries, and in the process, if you think Korea can play a role. Of course, there could be multiple roles that could be played by Korea, but the system and the situation are all different by country. So we need to provide a solution or a consultation in line with the situation of a nation. But this cooperation regarding laboratory should be done not by the government only, but by the private sector as well. That's why we need to establish a good channel for further communication between the public institutions and the private institutions. And in the case of a company, in the case of testing, it's easy to transport testing samples between ASEAN countries and Korea because we have a pretty close physically, and also we have accreditation management experience, and this kind of management experience could be also applied to ASEAN countries. Thank you for your answer. So not just the intergovernmental cooperation, but also the academic cooperation between Korea and ASEAN member countries will be meaningful, so that academia and our scholars can share their information about the pandemic as well as diagnostic testing methodology.
맞추어서 좀 기여를 할 수 있는 부분도 있지.
By doing so, I think we could make further contribution to the cooperation. So from the floor, we had one question. I think compared to Africa and compared to Africa and other regions, ASEAN did not have CDC. But in the long term, I think we should address this issue. And I believe this is a kind of open-ended question that cannot be answered here. But we need more long-term basis discussion about ASEAN version of CDC. Thank you for your attention, and thank you for being here with us. Thank you, everyone. This concludes our last session. We successfully completed our panel discussion. So please give them a big round of applause. So under the theme of better cooperation in the region to respond to the pandemic, we had meaningful panel discussion. In the interest of time, we were not able to make a further in-depth discussion, but I believe next year and going forward, we will have more opportunities to have network and make further discussion. Today we had many participants, and thanks to your active participation, we were able to discuss our measures against the pandemic in the region. And through this conference, hopefully you will have an opportunity to get meaningful insight. So this concludes the international conference for capacity building on our response toward infectious diseases. Once again, thank you for being here with us until the very end of the conference. It was Kim Hyun-jin, your host for the conference. Thank you.